To our November session of the Children, Adults, Health and Wellbeing Policy Development and Scrutiny Panel. I will, as usual, introduce the panel to everybody who's here in the room, and obviously remind all that this is being webcast, so if you don't wish to be on the webcast, then you probably should tell me. But I'm assuming that everybody does, as nobody's already said. Good. Right, so my name is Dina Romero and I'm the chair of this panel, and I also represent South Down in Bath. Liz?
Good morning, my name is Liz Hartman. I'm vice chair of this committee and I also represent Bolton.
I'm Michael Alton, I'm the ward councillor for Midsummer Lawson.
Thank you very much, Michael. Chris? Could you use your microphone, Chris?
Christopher Batten, representing National Education Union, non-voting member.
Chris. And Kevin?
Good morning. Kevin Burnett, Professional Association rep for the NAHT. National Association of Head Teachers and non-voting member.
Paul? Is your microphone not working?
You logged in?
I logged in, yeah.
There you go, you're all good.
Leslie?
Morning, my name's Leslie Mansell. I'm councillor for Radstock.
Thank you very much, Leslie. And Joanna, if you're ready, could you just introduce yourself?
Hello, Councillor Joanna Wright, Lambridge Ward.
Thank you very much. And we are ably assisted by Mark.
Good morning, everyone. My name is Mark Durnford. I'm the Democratic Services Officer for the panel. Thank you.
And Kerry.
Morning, Kerry Williams, and I provide the Scrutiny Officer's support to the panel.
Have I missed anybody? Oh, Barrett, sorry, because you were sat over there. Barrett.
Barrett Francaniak, Councillor for Coombe Ward.
Thank you very much. Have I missed anybody else? Good. So, and then when it is, if you are speaking, if you could introduce yourselves as well, that would be very helpful. Right, we now move on to the emergency evacuation procedure. Mark.
Great, thank you, Chair. Yes, if the continuous alarm does sound, you must evacuate from the building and proceed to the assembly point. From this room, you follow the green running person signs to the exit, using either the marble staircase or the main staircase. Please do not use the lifts. The assembly point for this building is the orange grove grassed area just outside Brown's restaurant, and there's an evacuation chair for use by disabled people who so wish in the corridor outside the council chamber public gallery. Alternatively, the area at the top of the marble staircase has been designated as safe refuge where persons needing assistance should assemble. Thank you.
Thank you very much, Mark. Do we have any apologies for absence?
Just two that I'm aware of, Chair, Councillors Siney and Harding.
Thank you, Mark. Any declarations of interest? Michael?
Yeah, just in addition to my role as a ward councillor, I also lead on the Community Catalyst programme, who work very closely with adult social care, and so I just feel it's important to mention that now.
Thank you very much. Any other declarations of interest? Okay, so the next item is urgent business, and I have none to announce. So item 6, public or councillor statements and questions. I've not been notified of any, and so I'm moving on. And we are now on the Cabinet Member update. Alison, is there anything you'd like to add? And would you introduce yourself as well, please?
Hi, I'm Alison Bourne. I'm the Cabinet Lead for Adult Social Care and Public Health for the Council. And my update provides an update on various things that have been happening since I last updated the panel 2 months ago. It also provides some information that's been requested specifically. One of those is in relation to the Fair Pay Agreement, and that is a government initiative which is aiming to improve the care the pay and conditions of people working in the care sector. And at the moment, what they're doing is going through a consultation process, and that's open until the 16th of January. Anyone is able to respond to that, and the link is in the paper. So that's the process it's at the moment. I was also asked to provide information on the Better Care Fund. The Better Care Fund has been around for a long time. I was trying to remember last night. I think it's, I don't know, 2008, something like that. I expect other people. Oh, that's correct. That's a good guess. Okay. Right, so it's been around a very long time. And basically, what it does is it provides a mechanism for local authorities and the NHS to pool resources and to use those resources to try to prevent hospital admissions and to expedite timely discharges from hospital. So it's about making the system work better in the community to support the hospital system. It's monitored really quite closely by the Health and Wellbeing Board. So I think we report to the Health and Wellbeing Board at every meeting, and the annual programme of activity is signed off and discussed by that board. But it's probably helpful for this board to also understand what it does and how it functions. So I think those are the two areas where a specific briefing was required, and within public health, I think we were asked for a briefing on long COVID and post-COVID syndrome, and there's information there on how those needs are met locally. So I'm happy to take questions on the rest of it.
Thank you, Alison. And I think what we'll do this time is we'll try and sort of work through the paper as it's, rather than sort of jump around. So I'll ask people if they've got questions on each separate item, if that's okay. So I'm going to start with the first section, which is on the fair pay agreement. I know, Barrett, you had your hand up first. Did you want to talk on this part, or? Okay.
So, Alison, I hear you about the fair pay agreement process. Of course, care workers deserve all the pay and fair pay. Of course they do. They're looking after our very elderly and vulnerable people. My point is this. I read in the same paper, in the same paragraphs, that of course, therefore, there will be a cost upon local authorities. And my counterpoint is this. Hold on a minute. These are private enterprises. This is a commercial enterprise. You charge a fee to us, and you don't want to pay the care workers. But when we ask you to pay the care workers a fair wage, you immediately say, we'll raise the prices so that the council ends up funding the extra cost. You know, my point is this. You're a commercial organization. Pay your workers a fair wage for a good service. Don't necessarily pass on your costs to us.
I mean, quite a lot of the placements that we make in adult social care are with commercial organisations, with private providers. And we have quite detailed negotiations with them around what we pay. And we certainly do not expect to be feeding enormous profits to those organisations. And I think because the market works well, we don't. So I think if there is an additional cost to that sector, I don't think it's unreasonable that they come back to us with that additional cost. But we do tend to work in a fairly open and transparent way with them, so we will understand the reality of their situation rather than just taking it that they need more funding. I don't know if you want to add anything to that, Suzanne.
Good morning, I'm Suzanne Wester, the Director of Adult Social Care, and I sit and involved in the national panel with the Fair Pay Agreement. And what the government is clearly saying is that they don't expect local authorities to pay much more than they already pay. There is a sense, and you know, both unions and the sector, the provider sector, are saying, and there lots of discussions are going on around this, is that they would be expected to take a lot of the extra cost rather than putting it on to self-funders, which in Bath and North East Somerset, 70% of our people are self-funders. So the government is not expecting to raise the cost for the self-funders, or neither is it expecting to be an extra pressure, a burden. They say they don't expect to be a burden on the local authority. However, and they will give 500 million towards that. However, I do expect to see some cost, and 500 million probably will not be enough to do that. Because at the moment, we drive down cost and push up quality. That's our responsibility. So I do think it will put extra pressure, and I know that the sector itself is struggling right now. But they are private providers, as you say, and they're expected to take most of the hit on this.
I feel comforted to hear that they will take the hit, because I think it is really important. Can I just ask a supplementary, which is, do we ever look at, I don't know, so I'm asking, you know, what were your profits compared to what you're charging us? Do we sort of say, please show us what your profits were?
We have an open book policy. So we like to look at if anybody, each year we look at inflation and we say, okay, it's this percent of inflation each year, and we keep that quite low. So we benchmark across other similar local authorities as doing well in the middle range. If a provider comes and says, well, I need a 20% increase, or you're not giving me enough, we then work through with that provider, and before we will increase anything, we have an open book policy, and we look at their books. We know what their the profit rate is for each of ours, and there's an expectation it's not more than a certain level, which is commercially sensitive, and we don't share that generally. But yeah, we know exactly how much they're making, what the profit looks like, and actually my experience has been that there's not great profits in some of these areas. You know, nursing homes, residential care homes, certainly not in adult services, because we have driven down the cost so much, and we've got framework arrangements with them, so that if a good example of that would be domiciliary care. You've got to bid for the work, you've got to be what we would call gold, you've got to have a good CQC rating, you've got to be good financially, and then we'll go with the best. So they're in competition with each other, so they have to drive down cost. So that's how we do it.
Thank you very much. That's a very full answer. Leslie.
Yes, thank you for the report. On the fair pay agreement, and picking up from the questions that Councillor Pankani has just asked, how will the Council ensure that the fair pay agreement aligns with the Council's broader goals for workforce sustainability and care quality? And on the link with profit versus pay, one of the lowest paid sectors in the country, there is a board or a panel that's going to be negotiating this fair pay agreement. Does this include the trade unions, and at what level? Is that locally, regionally or nationally? And what about where there's organisations that don't recognise the unions? Thank you.
That's all up for consultation at the moment in the document, and it's some really interesting times, because there's 3 unions that sit in the national negotiation at the moment, which we're in discussion with. How we as a council, I honestly don't know yet until we get feedback from the consultation. What I believe will happen, from what I've been told from the fair pay agreement arrangement, will be there'll be an organisation set up through the Employees' Right Bill, which is going through Parliament at the moment, and hopefully will go for royal assent in the next month or so. And that will be set up with local authority, commissioners, the provider sector and the unions. And that will be to make sure that the national pay arrangements are in place for all adult social care. And you will see in the paper that they talk about a national adult social care service in the same way as in the NHS. And you can see real advantages in that, because there's a standardisation and a fairness for employees, and that's what the Employment Rights Bill is going to put in place for the Fair Pay Agreement, and for us to be able to negotiate with unions. That question you asked me about providers, who don't recognise unions. In the Employment Rights Bill, there's an expectation that employers will recognise unions, and lots of the sector at the moment are waiting to see what comes from the consultation. Some of them already do recognise it, but generally not in the sector.
Thank you. Liz, did you want to ask a question?
I do. Thank you very much for your very comprehensive answer and for your in-depth questioning from Councillor Plancania and Councillor Mansell. The budget is going to be on us soon, and so there are going to be increased costs. I think you've admitted that the 500 million won't be enough. So have you budgeted for this in the forthcoming budget?
No, because the Fair Pay Agreement doesn't come until 28-29, but we're starting to try and model now what that would look like in our medium-term financial plan. And it's a difficult one, because you're modelling something you don't know what will get agreed or not, because it's out for consultation. But the aim would be that the adult social care staff will be in a similar pay arrangements and training and recruitment in the same way as the NHS for the adult social care service. So yeah, we've got some ideas and we're doing some modelling, and it will come into the medium-term financial plan. I've been asked to do that. So it's guesswork for me at the moment, but we need to put it in.
Thank you. And Joanna?
It says in the report that the Council plans to submit an official response. Will we be able to see that response before it's submitted?
That's one of the reasons why I brought it here, because I didn't know how because the consultation document is quite specific to an individual or a group. There's a number of things we're doing, so we will do, well, I will do a return. I'm waiting on a much easier consultation document where we can make some general statements, and I wanted to know how scrutiny wanted to do this, because it's in for the 16th, and I think it's the 18th is the next the next panel meeting for adult social care. So I was sort of opening that up for discussion, what you wanted to see and how you wanted me to present it.
Thank you, Suzanne. And I was just being reminded that previously the minutes from this meeting have actually formed part of that response, which I think would cover that point. But also as an individual, you can also submit a response to the consultation too.
But is it possible for us to see what the Council submits? Because we are the Council, and therefore it would be useful before the Council submits it, for at least it to come before this scrutiny panel, even if we're not meeting, to just see that document, so at least know what was being said on our behalf.
Of course, and I'm sure Suzanne will be very happy to share that when that's
Chair, that would have to be shared by email? Yeah.
Okay. If you send it to Mark, then Mark can make sure that it is circulated appropriately. Thank you. Okay, so the next sort of basically section in the report is on Newton House. Does anyone have anything else they wanted to add on this part? Kevin?
Yeah, thank you, Chair. I just wondered if you've now got a timeline you're working towards and when we might be able to see that, or any deadlines you have for change of what the provision is going to be.
We have been working with the providers on a timeline, and we need to go through procurement around this, so I'm not ready to share it at the moment. We have a timeline, but I've got to make sure that we do this through procurement rules. But I do think that I'd probably be able to bring it in the January panel.
Thank you, Suzanne, and we will expect it in January. Thank you. Liz?
Just to clarify, you're looking at commissioning building-based services. Are you thinking of Newton House still, and are the families happy with this, or what are your plans?
I think when we go out to procurement, we'll see what comes back. We know we want, from what the families have told us, because we're working with 24 families overall around who use Newton House, and that's for respite for people with learning disabilities. But our policy is looking at all age. But when we go out to tender, we'll see what comes back. And I don't know whether the organisation who runs Newton will bid for that or not. I'm assuming they will. But yeah, it's really important that the families have told us we need residential based, and we want it local, and we don't want it outside of Baines. It needs to be somewhere where we feel our people can be well supported. So there's a couple of things that are in there which families feel very strongly about, and that's why we're working closely with them. There's 3 reps that come to a regular meeting, 3 or 4. There's always 3 in the room, but there's 4 of them, and then they feed back to the bigger group, and we go to the bigger group as well. But we've had some very good feedback. So yeah, it will still be residential, but how that will look will develop with the families.
So the residential will need to be suitable for people with complex physical needs as well as learning disability. So that will, that will guide, I think, the outcome that we get.
Thank you. I'm glad to hear that. Next item then is the dementia strategy. So next section. Any questions on this? Michael.
In the notes on strategy, you list the different multi-agency steering group that's been put together for that. And I just noticed that the Ageing Well Network is not there by name. And I'm just wondering how important they are. But I know how important they are in terms of what they've achieved. And their 18-month report, which has just come out, really shows how effective they've been over the last 18 months. So would they be part of that steering group at all?
They're very much part of it. I don't know why they're not named in there, but they're very much part of it. That's part of the leadership of the strategy. So, yeah, apologies.
Perhaps we can amend the minutes so that that's noted. Leslie and then Barrett.
Yes, I've got various questions on this. So, what steps are being taken to ensure equitable access to dementia services across the urban and the rural areas? Bear with me.
Are they linked, your questions, Leslie?
Sorry?
Are they linked? Do you want to ask both your questions?
Sorry, I'll say that again.
So do you want to ask both your questions?
Yes, yes, please. And also, how will the council promote dementia-friendly environments in public services, transport and local businesses? Thank you.
Okay, I'll start this time. Equity of access will be one of the primary things that will be looked at within the strategy. It will be one of the principles that underpins it, so we will be seeking to ensure that people across the authority do have access to appropriate support. And your second question was about dementia-friendly, being a dementia-friendly area. And when there is a separate piece of work that's going on about making Bath and North East Somerset a dementia-friendly authority, and that's being led by Age UK, but the council is working very closely with them on that, as are a number of other partners, and that includes a whole range of areas that they are working on, and some of that is around training of people who come into contact with older people to make them more aware of their needs and better equipped to meet them in an appropriate way.
Thank you, Alison. Can I just check? Did you say Age UK or were you talking about Age Baines? Okay. Yes, that's what I wanted to clarify. Thank you. Barrett.
I'm aware of your dementia strategy and what you're doing and what you're providing. I wish to just take a different angle, okay? And the angle I'm taking as a public health doctor is we cannot manage an avalanche of people with dementia or any other illness, okay? So what I'm trying to tease out is, do we have dementia prevention strategies? And what I mean by dementia prevention strategies is we have now ample evidence of certain things that we can do which therefore seem to be dementia protective. One of them is dietary interventions, that Mediterranean diet of nuts, berries, rainbow-coloured food, exercise, and then there is a little bit of evidence around the use of, for example, the shingles vaccine, which seems to, maybe it may be right, which is delay or prevent dementia. What I'm getting at is we really must always look at how can we prevent it, because by the time we have the cases, it's too late and there's not much we can do. I also appreciate it's not in your remit, but I thought I'd just ask.
Yes, I absolutely agree, Bharat. It is an important thing to do, and my understanding is that the measures you take to prevent dementia are the same measures that you take to prevent heart disease, pretty much. And I think there's been a lot of work going on in that area for a long time, but I think I'm probably going to hand over to Becky, who can answer more fully, because it really is a public health issue.
Yeah, thank you. It's a really valuable question. So a lot of the work that we will do in public health and with our partners around improving levels of physical activity, improving healthy eating, and a lot of that work is commissioned through Everyone Health, our newly provider, who provides a lot of the health improvement work. And we're developing a health improvement framework called Wellbeing that tries to bring a lot of those areas around healthy eating, moving more, as well as some mental well-being and some work on some community cohesion type work, brings together a lot of those areas. It isn't specifically identified as dementia prevention, but it will all absolutely contribute towards a healthy population. And then the NHS Health Checks programme, when you hit a certain age, also has questions around memory. So it's trying to identify early people who may perhaps have early signs of cognitive impairment and refer them on to services as appropriate. So a lot of that prevention work is ongoing. It's not just necessarily flagged as dementia prevention, but around trying to keep people fit, well, healthy, and people looking after themselves as well and taking care of themselves and sharing information around that.
Becky, of course I agree with you. What I want to say is habits formed in childhood are lifelong habits. And because habits formed in childhood will prevent the future cases of heart disease, stroke, dementia, I'm energized and really concerned that all our schools have those activities, in other words, sports fields. I'm very concerned that, there is question mark around my own ward where they may lose some of their sports fields. And I think we as health advocates, people who really want to create habit of you exercise from childhood onwards, that we make sure we don't lose our green spaces, because our green spaces in the pressure of build, build and build will actually make us a more ill population. We need those green spaces and we need to hold on to them.
Yeah, thank you, absolutely. And that sort of brings in the whole system type work. So from a public health perspective, we work incredibly closely with the Green Infrastructure team in the Council, who are looking at developing their green infrastructure framework, so looking at what the green spaces are, and the blue spaces if we think about water and using water creatively, and what the plan is for Bath and North East Somerset over the coming X number of years to protect and, where possible, expand those green spaces. And I was going to say one more thing. Oh yes, we're right at the time at the moment of carrying out a survey, which we have to do every 3 to 5 years, on our sports fields. So it's our sports field strategy. So that work is happening at the moment with an external person who's come in to do a lot of work to map the fields that are available. Part of that is around protecting them, and that will feed into the local plan. So that absolutely will inform local plan policies going forward, because you're absolutely right, we need to be working with our schools to protect those green spaces. We are in a slightly different position in Baines because so many of our schools, the vast majority, are multi-academy trusts. So we work very collaboratively, particularly through our Director of Education, Chris Wilford, through the School Standards Board. And yeah, that's a conversation I'll pick up with Chris a bit more. Yeah, thank you. Thanks for your question.
Thank you. I don't think I had other speakers on this section, so we'll move on now to Community Support Contract Awards. Any questions on this part? Kevin.
Thank you, Chair. Yes, forgive me, I just want to try and clarify. Is this the same, or heading as when we were thinking quite a considerable while back about saving money and that the contracts weren't out, and then there was the issue of liaison and so on. Yeah, it's the same sort of thing. So are you at a stage now where you can tell us if we've got to that point where we know what we want, we've saved X amount of money or not, and the third sector has been very much a key part of what's being produced?
So way back when, I think it was 3 years ago, we said 802k. That was the saving that was up again against the contracts between housing and adult social care. They were the savings that we, as a council, had agreed, and we brought them here to you. From there, we worked very closely with the sector about, it's been 10 years since the sector's contracts had been reviewed, well actually 7 years since the contracts had been reviewed. And we talked to the sector, we had lots and lots of different meetings about what were the needs of the local people, what was the greatest need. We set those services, those 6 services that are set out there with the sector. We have achieved the savings we needed to make with their help. We haven't cut any one service. We went through a procurement, which we've now identified the providers that are there who are now implementing the community services are implementing the work now, which will start and be in place in January. We had a lot of work to do to make sure that we took efficiencies out without affecting people who were using the service, because that was really important. We also had to we needed to ensure that the providers that we awarded the contracts to, that they were doable, you know, they were fair and they were doable. I would say if 3SG was here, it was a hard process. There was a lot of negotiation, lots about protecting those most vulnerable and making sure that we're doing the right thing by those. And with the help of the sector, we're now working on the next phase of learning disabilities and mental health. That's our next phase over the next 2 years. So I know we achieved the saving, but I also know that we've done that with the great support of the sector. We wouldn't have been able to do it otherwise, protecting the most vulnerable. So that's how we've done it. It hasn't been an easy approach, but we have achieved it.
Thank you very much, Suzanne. Thank you for the question, Kevin. Leslie.
Yes, a couple of questions from me on this. What is in place to evaluate the effectiveness and impact of the Commission's services? How are people with lived experience being involved in shaping them? And how will the Council ensure that services are culturally competent and accessible to diverse communities?
So I'm going to take the evaluation question first. So we've got regular evaluations. We're talking with people who've receiving the services. We're sending out questionnaires, just checking how things are for them. We're working with 3SG to make sure that they're culturally suitable for the organisations that are working with those people. We've got regular feedback. They've got direct commissioners working with them who've got a set of standards to review each of the contracts to make sure they're achieving the areas they're expected to achieve. There's a lot of work the commissioners and contract managers do on our commercial side to make sure that those contracts are achieving what they need to and that they are culturally sufficient as well within the area. There's a whole process. We've got a quality assurance process as well, so that if there is an issue with any of the providers, they know where to come, they know who their connections are.
Okay, thank you, Suzanne. Leslie, is that... So you look like you've got another question.
Did we miss the vocational hub?
We have, and I am aware of that, and I was coming back to it. Okay, so are we done with this section, and then we're going back to the part on the vocational hub. I know Liz has a question.
Thank you. Some very good work is going on here, but I just have a couple of questions about this. So, for example, how do people access this? There are 55 people involved. Is that a small number compared to the numbers that are out there? And what level of demand is there for this? And just 55 people are accessing it, so just a little bit more information on that. And then, what challenges are there for this service?
Thank you, Councillor Harman. There is a range of employment services across mental health, learning disabilities. ICB is also doing some work. We've got other providers in the area. So this is just one small part of what we're delivering around the vocational hub. It's fair to say we've got a piece of work to do around this about what is our offer, and that's one of the things that when this came up to come to this panel and conversations that we've been having, is that we would like to pull together a whole offer across learning disabilities and mental health and make sure that we're working with other vocational establishments because 55 is quite low, but I've got 150 somewhere else and 200 and you know, in all different areas. So this is the next piece of work we're going to be doing in adult social care, because it's really important from the point of view of somebody with a disability who wants to come back to work, or you know, volunteering or some meaningful activity, that they get the opportunity. And we've got some really good businesses locally who want to do more of this. So some of our anchor institutes, like in RUH, some of the universities, they're all interested in doing this work. We need to make sure that our offer is clearer to everybody. We're still getting referrals in, but we've more work to do to even generate more referrals.
Thank you. How do people learn about this, and how do the referrals work?
Usually, not always, but in most cases, they'll have a Care Act assessment and they'll be referred through in that way by their social worker. But there are other ways of coming in through the voluntary sector as well. So people who don't need a Care Act assessment but actually have a level of need, they come through that way as well. And we want to try and streamline some of that to make sure that everybody is aware of what they're entitled to around returning to employment or as a meaningful activity.
Thank you. And probably...
Sorry, can I just clarify there? These are people who come through the learning disability route primarily. There are other routes, and people tend to go through to other services through the other routes currently.
Perhaps an updated report on this later on?
Yeah, give me some time, because I think it will be the summer by the time we'll be in a position to do this, but I do think it'll be an interesting piece of work, and it'll be co-produced with the people who are using the services and what they want and what they would find helpful, and with local business.
So we should expect something, or we could ask for something after the summer, so whichever September, October meeting. Okay, lovely, thank you. Leslie, you're next to my list.
Yes, it's quite a short part of the report, but it's a really important part of it as well. And it's really interesting to hear what you're saying, Suzanne, about the co-production. This is something that's embedded within the NHS 10-year plan. We also had a 5-year plan within the NHS to employ more people with learning disabilities. What we didn't have was the resources to support that, which is always a concern. So what training or support will be provided to employers to ensure meaningful and supported placements? And will the hub align with existing services like the virtual school, Youth Connect and Bath College? Thank you.
Yes, it will align with all of that, the virtual college, and just thinking about the work we're doing around all age, in particular young people who are transitioning into adult social care. We want them to be able to come with aspirations for employment, training, and meaningful activity for them as well. I think one of the issues for us is that the level of demand could be greater if we could. We've got a new marketing and comms officer working with us at the moment, and one of the areas will be to make sure that we market employment and supported employment across adult social care, so we get more people through employment. We do support local businesses, so we've got dedicated workers that work with the businesses and support the people coming through into that business, but support the business as well. So in a number of our areas, we already have that in place. More would be helpful, but we have limited resource.
Sorry, can I add a bit to that again? I visited the Employment Inclusion Service at the IUH, which comes under the umbrella of this, and was really impressed by the level of support that's provided there. And they work both with the teams who the person who's being placed is working with to help, prepare them for to make the correct adjustments. And they also provide ongoing support for as long as the person needs to enable them to stay in that job. And the people I spoke to there, really, really happy with the work that they're doing and feel very valued and feel that they are doing a proper job and receiving proper pay for the work that they're doing. So it was really, really very impressive, and I would hope that we will be able to get to do more of that. And I hope, given the government's desire to get more people into employment, that it will be investing in this so that we can do more.
Thank you, Alison. And I think they had offered to come and speak to this panel a few months ago, so maybe we should follow that up so we could hear perhaps straight from a provider as well. Thank you. Next part of this report is on the Better Care Fund. Can I say thank you, Alison, for I think clarifying exactly what the Better Care Fund is for and the sort of length of time it's been in existence as well. Are there any questions about this part of the report? Thank you. And then the opening of the new OT Assessment Centre. Has anybody got any points they want to make on that? Michael?
Yeah, I just wanted to ask if it's possible as the local ward councillor to go down and visit, and particularly because it's right in my ward, and I'd be very keen to go and support if I can.
That would be brilliant, yeah. Let me organise that and I'll go with you, because I haven't been there in the last month. I've been there a couple of times in the last month, so it's a good opportunity for me to go as well. So let's do that.
Thank you. So now we're on the public health part of Alison's report. And firstly, there's suicide prevention update. And I know Alison spoke at the conference that they had, the annual conference. So I wondered if any questions or any comments from our panel. Okay. Then oral health. Sorry, Leslie, did I miss you for the last bit, or was it on oral health?
Yeah, yes, on the suicide prevention update, which is really welcome. What measurable outcomes have been achieved through the current strategy, and how are these being evaluated? I think we need to have a look at those. How is the council addressing the needs of disproportionately affected groups, such as men, LGBTQ plus individuals, and those in rural or deprived areas? Thank you.
I don't know. Yes, so Becky, I'm sure. Becky, sorry, I didn't ask you to introduce yourself before. Would you do so this time?
Yes, certainly. Becky Reynolds, Director of Public Health. Thank you. So just to make sure I've captured them all. So the current strategy and how the strategy is, what the outcomes are from the strategy. Is that right, Councillor Mansell? And then how the strategy is targeting vulnerable populations. Okay, so the current strategy has very recently been updated, and what's being developed at the moment is an action plan, and that action plan should be finalised by the end of January, beginning of February, and at the moment many partners are contributing to that action plan. The national framework, the national action plan, sets the framework for work across Baines, Swindon and Wiltshire suicide prevention strategy, and then Baines flows from that. So it's very much tied into what the evidence is saying the priorities are for action, both to prevent and reduce the risk of suicide, and also to support people who are bereaved by suicide, and to share information and to destigmatise suicide as well. We know we have some evidence of who our vulnerable populations are. Our populations more at risk of suicide, be that men more than women, for example, and particular population groups. And so that is informing our strategy and our direction of travel, and that will certainly be seen in our action plan once the action plan is finalised. So we would be very happy to bring the action plan here at some point in the future if the scrutiny committee would like that, if that would be helpful. That action plan is also monitored, so in terms of how it is achieving what it's setting out to achieve, it's monitored on a quarterly basis through the Baines Suicide Prevention Group. And as I say, there is also a Baines, Swindon and Wiltshire suicide strategy group as well, because we need to be, obviously, there's a lot of flow across borders, and so we need to be working very closely with our colleagues. We also work very closely with colleagues across the Avon and Somerset police footprint, because the real-time suicide surveillance system operates on that footprint, and that is a really key way in which information is shared in a very timely way and a very sensitive way to offer support as soon as possible for people who've been bereaved by suicide. Because we know that one of the most vulnerable times for someone who has been bereaved by suicide is in the months following a suicide. They're more likely to take their own lives at that time. So in terms of focusing on vulnerable populations, that is a population group who is very vulnerable. So working hard, really hard across the police footprint to share information so that we can provide signposting and referral to the bereavement support service, specifically for people bereaved by suicide.
Can I just come back on a point there, because it just set an alarm bell going. So Becky, you just talked about the plan being across BSW, but we understand we're going to be in this much wider cluster with the rest of Somerset and Dorset. So how are those, presumably they're going to have an action plan as well, how are they going to link together?
That's a good question. It's a really valuable question, and that will be a question that's considered both in terms of the suicide prevention strategy work that's going across BSW, but also all the other work across many different topic areas across Baines, Swindon and Wiltshire. So the strategy and the plan that Baines has is specifically for Baines. There is a BSW strategy, and from that we have developed our Baines strategy, and we are developing our Baines plan based on the needs of our population. But those conversations about how the different ICBs, when they cluster together, maybe something either Laura or Lucy want to pick up in a second, but that would be part of the ongoing conversation about how to, the different strategies and plans that sit across those different ICBs that are clustering together, how over time, what will happen to those in terms of being brought together or not, remaining as separate pieces. That's a bit of work in the future.
I'm sure
Laura... Be assured, we've got a Baines plan and a Baines strategy. Thank you.
I'm sure Laura will refer to that when she makes her comments. Thank you. Right, my list. Let's see. Barrett and then Joanne.
Thank you. Thank you, Becky. I have a lot of interest in this. I did a lot of work on suicide prevention, so I come from my own background. I don't see anything in here, Becky, which tells me we've got things in place for, see, what tends to happen is deliberate self-harm, and then that's the first signal of things are not right. And then you have an escalating deliberate self-harm, and then a further escalating deliberate self-harm, and one of them leads to a successful suicide. When I was in West Surrey and North East Hampshire, I actually copied the green card scheme, which had been created by David Gunnell from University of Bristol. And what the green card system is a person turns up in accident and emergency having done a deliberate self-harm, which could be paracetamol poisoning, cutting, carbon monoxide, or something. That is the place where rapid, in-depth intervention will prevent that further escalation of deliberate self-harm leading to eventual successful suicide. So what tends to happen in A&E A&E is geared up for A&E. And they're already overrushed and they're already in difficulties from staff resources and so on and so on. But at that point of presenting in A&E, there needs to be a defined pathway whereby you arrived, we captured you, we are now going to refer you, and we're going to refer you now, we're going to refer you to the mental health services, and it's not like somebody will get in touch with you within a few weeks. It's a case of, here you are today now, so we're now picking up the phone on your behalf, and we're now going to call the mental health services and say to them, we have here a deliberate self-harm patient, we want you to intervene, and we want you to intervene urgently. It's those sort of things that I would like to read about. Maybe you already have them in place, but I don't see it here.
So I know Lucy also wanted to come in.
Yeah, no, I was going to say a lot of this. I know that my colleagues work very closely with the ICB, and I know that Lucy's been putting a hand up as you've been talking. So if that's okay, I'm going to pass to Lucy. With it sitting, she'll talk about the join up.
Hi everyone, I'm Lucy Baker. I'm the Director of Learning Disability, Autism, Neurodivergence, Children and Young People and the Combined Place Team for BSWICB. Thank you for your question and just a bit of an update if I may. So within our emergency departments in hospitals, we have mental health liaison teams that are based in the emergency department who see people as they attend. We also, as a local system, have funded Bath Mind to have a presence in the emergency department to pick up those individuals that might not meet the threshold for secondary mental health services, but can wrap around the individual at the time they present. That also then links into our community mental health framework that's been commissioned about providing ongoing support for individuals after that initial presentation. So I think over the last year, there's been a significant change in the offer for people who present with deliberate self-harm in the emergency department to get that early intervention and prevention to try and reduce future risk.
Thank you. Barrett.
Yeah, thank you very much. I feel reassured. Just a supplementary, if I may, please. So is this cover 24/7 or how does it work?
So mental health liaison presence is available till 8 p.m. If people present overnight, there is availability as well with an on-call system, and then people are referred into Bath Mind the next day. So there is a very quick process for identifying how to reach out to those individuals. If there is any risk identified, the person is kept in the emergency department until they can be seen.
Look, I feel good to hear this. Can I just ask one more, which is, I think there should be an audit system. In other words, it's lovely to hear this, but I'd like to see, therefore, we had so many people, and therefore we referred to them, and therefore they were seen within 24 hours. We just didn't discharge them. You know, some of that, audit system, because it really is good to capture that actually we're doing really good work.
Data, so I'm very happy to share that in the future.
So perhaps what we could do, as I note that the strategy has just been refreshed, maybe we could have that come to our, which meeting would that be, January meeting?
For adults.
Yes, yeah. Alongside so we could have the strategy plus the audit part that you're asking for too. Okay. Next, I have Joanna.
Thank you. I just wanted to know, do we have data about care experienced people in the suicide prevention work?
From an NHS perspective, yes, we do collect that data on care experienced people.
Could we have that in the report too, about how we're working with them to support that group?
Of course. Thank you, and I think Lucy's made a note of that now. Apologies, my screen just was refreshing itself. Oral health, were there any questions on this? Yes, Liz.
Well, it's good to see any kind of dental service being extended, but I believe this could be for the ICB maybe to answer this. Apparently, a service called At Home Dental has been commissioned to deliver oral health training to workforces across Baines, and I'm intrigued to see that quite a number of workforces like childminders, learning disability team, children's centres, elective home education team, the workforce are being trained. So what are they being actually trained in?
So they've been trained in working with the children that they're looking after around cleaning teeth, so around oral health. So they're working with staff in those organisations so that staff are able to talk with children about how to clean their teeth well and what it means to clean their teeth well. In terms of the care home work, they're training care home oral health champions who would then be champions in the care homes to support good oral health within the home.
And is this being extended into schools? I know schools are expected now to do everything, but I've noticed my little granddaughter has a little rhyme that she says when she cleans her teeth. I'm just wondered, is something like that being introduced into the schools as well?
I would need to check the actual details. We do have a separate existing supervised toothbrushing scheme in nurseries. I'm not quite sure. I would need to check the age at which it goes up to, whether it includes reception. This is an add-on, this is extra, so this is a new contract which is really welcome, and it's a 2-year contract plus one to focus on the childcare and older people's settings in particular. But I'll check around the supervised toothbrushing and what age within primary schools that goes up to, where it's offered. Thank you.
Kevin, and then Barrett.
Thank you. I was just intrigued to understand whether there was any feedback from schools. Listening to your last comment, so you may not have that to hand at the moment or even know if it's extended, but it'd be useful. I asked a little while ago whether there was feedback from schools and how it was being done within schools, please.
The only general feedback I have at the moment is that some schools find that they don't have capacity or time in the school day, which is why we don't get all of those schools where we're working with the nurseries. We don't get all of them signed up who are eligible, and we work very hard to try to make it as easy as possible and to have multiple contacts with the nurseries and with the early years to encourage them. It's around capacity and time. I can find out if there's more detailed feedback, but it's largely around capacity and staff time.
And have you sort of taken that on board and thought of different ways around that?
Yes, absolutely. The team does try to do that and does have some successes as well. So they don't give up easily, because we know how important oral health of children is, especially as they become adults. So we do work very closely to try to make it as easy as possible and to see when within the school time. I mean, ultimately, it's up to the school to determine when they would be talking with children around oral health and keeping the teeth clean. So we do try to absolutely be as flexible, or the team is as flexible as possible in trying to enable greater uptake.
Yeah, I was obviously just to see whether you are putting the onus on the school or whether you're taking the onus, if you like, and the capacity and the delivery of.
Let me come back to you with the detail of it, if that's okay. Thank you.
Thank you. Barrett.
Thank you, Chair. Becky, you'll be fed up of listening to me. We know that this is an elephant in the room. It really is. United Kingdom, a powerful economic country, cannot afford dental care for its people. And that is the elephant in the room, really. What I want to talk about is, can I sort of ask the Integrated Care Board or people with the money to say, we're going to set up mobile dental clinics to provide dental care, because really asking ordinary people, who are not experts in the business of teeth brushing, etc. It's an art and a craft and difficult, and it's not easy, and if you're a teacher, you're a teacher. You're not somebody here to teach people how to brush their teeth. And I know Becky is doing her best under the circumstances that dentists on the NHS are not available. But good dental health is good health. And we are failing our citizens. And really what we should be doing is address the elephant in the room, which is provide good dental care for our children. you know, and one of them could be, for example, mobile dental clinics. So coming on to what Becky's trying to do a good job under the difficult circumstances. What can you do? But, you know, if you have set up this thing, let us see the evidence that therefore it works. Therefore there is good dental hygiene. Therefore there are fewer caries. Therefore there is less gum disease. I doubt it very much. But if Becky can show it to us that it works, I'd be amazed to learn about it.
Thank you. I don't know if Becky or Lucy or Laura wants to respond.
If I just come back on the supervised toothbrushing, it is an evidence-based programme, so there is some excellent evidence about how effective it is. In terms of your important point around access to dental provision and mobile dental services, then probably I'll hand over to my NHS colleagues.
Yeah, thank you, Becky, and thank you for the question. I'm Laura Ambler, I'm the Exec Director of Place for the Integrated Care Board for Baines. So, as Becky says, yeah, the toothbrushing is definitely an evidence-based programme. All of the programmes are. Colleagues here will remember that Victoria Stanley from the ICB has come along to present on the dental strategy. My suggestion is that we ask her to come and give us an update. If you recall, she talked specifically about children and young people. We know that in Baines, probably the performance benchmarks relatively well. But what that does is masks pockets of deprivation, as we know, and we knew in particular, I think we had the term, didn't we, dental deserts, and we talked about mobile bans. Yes. And whether there was something that could be done there. So I suggest, Chair, that we come back and provide a future update on that. There has been work in this space. There has been a lot of additional commissioned dental activity units, which is how they count it, and I'm sure Victoria can come and give us an update.
Thank you. I think that would be very gratefully received. And if it's at all possible, to remind her that we do have a meeting in December, which has a children's focus. So I think sooner rather than later would be appreciated. Yes, Joanna, you are next on my list.
Just to pick up on that, because we have done so much about dental deserts and the work here, I'm just wondering about free school meals. We know where children need free school meals. So should that be where those pockets of deprivation are and those visits are made?
I'm not sure who wants to pick that up, Laura.
I'll take that back to colleagues and ask, because yes, I recall that we were saying that there were different layers of information they should look at to target services.
So I'm just going to ask a very quick question. Were things better with our children's teeth and oral hygiene when we had, you know, the regular programme of the little tablets and the toothbrushes and toothpaste? I think this was probably led by, so we say, a toothpaste company as an initiative. But I just wondered, were things better in those days, which was possibly a very, very long time ago?
Yes. We're in such a different situation now, aren't we? Food is so readily available, sweet food is so readily available. We're in a fast-moving world where sometimes children may have a very fast-moving morning, and cleaning their teeth may not always be a priority. The availability of food is everywhere, and sweet food is everywhere, and that's what attacks our enamel on our teeth. So it's difficult to say. It's a good question, but difficult to answer exactly.
So it was suitable perhaps for the times it was in. Okay, let's move on. So the next part of this report is on the Oddam Sports Ground. I think this is just really just mostly to note, because I assume people who sit on the planning committee should not really comment on this part anyway. Is there anything, does anybody have any comments on this bit? No? Good. National Pandemic Planning Exercise. I'm fairly sure I know that there will be people who want to ask questions on this. Barrett.
Yes, exercise Pegasus took place, and there were a lot of players, and I'm aware of it. My own departments also took part in it. What I want to say with respect to pandemic planning and our local place here, what applies here applies nationally, is this: we had exercise sickness before the pandemic, SARS-CoV-2 pandemic hit us. And we found that whilst exercise sickness had identified that we won't have bed capacity, we don't have PPE stores, etc., the findings of exercise sickness were not implemented. What I'm getting at is we've recently had exercise Pegasus. Having had exercise Pegasus, there are findings and then there are things to implement. What I would really like, and unfortunately this has to be a national thing, so at least we can put it on record that we asked, which is this. Where is the evidence that whatever exercise Pegasus identified is going to be implemented, and how will we know that it has truly been implemented and it is in place were a second virus, airborne type pandemic appear on our shores?
Okay, who would like to take that?
I think that's a question directed nationally, really. Absolutely, absolutely. Yeah.
So, is it a question then that you can feed up to the national coordinators of this exercise?
So yes, as the Councillor said, this is a national exercise. It's a Tier 1 national planning exercise. So it happened across the country and all 4 nations across the country, involving many different partners, many different players, and led through the local resilience forums locally. There are a number of debriefing sessions which provide opportunities for partners who took part in Exercise Pegasus to feed upwards how we found the exercise, and that is certainly a question on our minds and a question we will be asking. I imagine, I would hope that there will be great scrutiny on this exercise compared with previous, because the need for this exercise has come out of the COVID inquiry from the first module about the fact that the UK was not prepared for COVID. So it's a response and it's an action that's come out of the learning from the first module. So I would hope that there is a lot of scrutiny nationally on, so what difference is Exercise Pegasus making and how will we know it is making a difference? But yes, I will certainly ask that we be taking that question forward and ask other colleagues to do the same. Thank you.
See any learning from that briefing, I think we would appreciate seeing here in due course too. So thank you. Liz, I understand you had a follow-up question on that.
Well, I think you followed up my followed-up question, because I was wondering what were the findings that you found out, that was found out at this event that took place, Pegasus, because it would be interesting to share it with us. I know it was a national thing, but surely there were implications for us as a local authority. So perhaps, maybe, that could be part of your report in the near future. Thanks.
I'd be delighted to. Thank you for the opportunity.
I have Michael and Kevin on my list. Michael.
I'm not sure it's 100% relevant, really, but during the time of the beginning of COVID, I did a lot of work with Bemska, and one of the questions I wanted to ask is, in terms of kind of multi-agency response involved in Pegasus, would you be engaging with the kind of minority communities in terms of how you get the communication out about the need for vaccines, and certainly the learning from Bemska in the time that I was with them was about the methodology that was used in communicating with Bemska members. And we put together a questionnaire, but actually questionnaire was not the best way. It was actually about the one-to-one support to talk to individual people that were concerned about some of the issues around COVID and whether vaccines were the right thing or not. So I didn't know whether that kind of learning gets fed into any wider preparation that Baines may be looking in terms of future viruses and future outbreaks.
Yes, thank you for the question. Absolutely. So this national exercise took part over 3 separate weeks, mimicking, in a sense, an escalation from a few cases globally to a full-blown and internationally declared pandemic. And the local partnerships needed to complete workbooks. And a big part of that exercise was around inequalities. Who are your more vulnerable groups? How would you make sure that you're communicating with, you are engaging with, you are learning from and hearing from vulnerable groups? And so Vemska was an example of a local group, along with many others, when we were thinking about who our vulnerable populations would be, who we would need to be communicating with very, very early on and learning from and developing materials with. So yes, so we'll make sure that when we bring a report around the learning that we've done for BAMES, so that we are in the best position we can be as a council, should a future pandemic occur, that will include addressing inequalities, if that's okay. Yeah, thank you.
Thank you. Kevin, I think you're last on my list.
Thank you. I just wonder, Becky, if there are any specific things to BAMES that came out of this exercise that you think actually we could do something about here?
I think it's perhaps a little bit early around BAMES. I think one thing that was different about this exercise was that the national exercise simulated a higher proportion of children who became ill and who died than adults, compared with COVID. So in other words, it was children who were particularly becoming ill and higher risk of death from this exercise. And I think that will have an impact, a different impact than COVID would, because parents of children, our concerns around our children may well mean that we might respond, people might just respond very differently as a pandemic was escalating that impacted on our children more than it might do for older people, if that makes sense. And then when we think about the workforce, so many of our workforce have younger children. So that's where I felt there's a much bigger difference. That's not specific to BAMES, that will be a national thing, but that's where there's a much bigger difference. How would we respond as a population, knowing that this particular virus impacted more severely on our children and young people? With any particular learning to BAMES, we will make sure we bring that as part of the report, because we're taking it to CMT as well.
Will you be reporting back on those implications and what was, if you like, the results and what's going to be done next?
Yeah, so all local resilience forums with the various partners, when they took part in the exercise, needed to feed back, sort of talk through how would you respond if X happened, and then feed that back. So that's all happening in terms of being fed back nationally. We will take the learning from it that applies to us in BAMES, with our wider partners, with our NHS partners very closely, and voluntary sector partners as well, and think what are the actions, therefore, that we need to take to put ourselves in the strongest position to prevent and prepare for.
And that will come back to panel?
Yes, I think that's what we're saying. The report will come back to panel.
That's what I've asked for, Kevin.
Yeah.
Okay, thank you, Becky. Okay, so the last part of Alison's report is on long COVID. Okay, yes, I'm going to take Barrett first and then Kevin.
Thank you, Chair. Long COVID is a difficult thing, and I just wanted to say, look, as somebody who's in this business, it is for real. It really is for real. We have people once upon a time who were running marathons, very active physically, and suddenly are disabled and cannot really function. So it really is as real can be. We might not see those cases of long COVID, but they are there. My concerns are, we don't know who's going to get long COVID. We don't know what the cure is for long COVID. These people are going to remain disabled for a long time. So we need to prepare for it's unfortunate, it really is unfortunate, but an increasing burden of people who are going to become economically less active. This is a rising tide of more illness to come. So then that takes me to, well, what would I do? And what would I do is I'll try and prevent cases of long COVID from occurring. I don't know who's going to get it, but you do get it if you get infected. So what I'm looking at is, what can we do to minimize people getting infected? And that includes things like investment in good ventilation services, people information, so then they can make their own decisions about, I want to avoid those closed, crowded, poorly ventilated places. Because we can only do what we can do, but at least if we say, listen, long COVID is real. We don't know who's going to get affected, but if you are affected, my goodness me, it's very serious. So we, the local authority, could do our little bit, which is in the schools, in our public offices, in our buildings, have that, information, which is infection prevention is a good thing, because we don't know who's going to get long COVID, and repeated infections also are not a good thing.
Thank you. Shall I go straight to Lucy?
Thank you, and absolutely agree with your sentiment about the importance of good infection prevention and control. Just on long COVID, we continue to commission a dedicated long COVID service, which works on capturing data on the number of people who are impacted by long COVID, and that feeds into the national system, which has actually shown reduced prevalence of long COVID since the pandemic was in place. That national funding around long COVID actually comes to an end in March 2026 due to that reduction in prevalence. But what will be available in the Baines area and across BSW is access into community services as that long COVID provision becomes part of our business as usual commission services. And that will be based on the needs of individuals, which do very much vary from individual to individual in relation to those who still present with long COVID. So we've got a dedicated service that remains till March 26, and then that will transfer into community needs-based support after that date.
Thank you. I wonder if we should have a report back on long COVID. I'm trying to work out when that would be, probably in January. Barrett.
I just wanted to say on the subject of there might be an apparent reduction in prevalence. My view is, well, we don't know, because repeated infections may precipitate finally presenting with long COVID. And therefore, I don't think we should take our eye off the ball, which is, look, the prevalence is actually less than we thought, or it's decreasing. We don't know. The only thing we do know is the more infections you prevent, the fewer the cases of long COVID you will eventually have. And as we know, long COVID, once you've got it, there's nothing you can do. So really, our big focus should be on prevent that infection.
Okay, so maybe that can be picked up within my request for more detail in January. Okay, thank you. I think, Michael, you're on my list. You are now. Kevin and then Liz.
Yeah, thank you, Chair. I think my biggest concern is the fact that COVID, rather than like Barrett was talking about, this ticking time bomb, as far as schools are concerned, it's gone away. If I ask in any forums about the monitoring of COVID, how many instances of COVID, are ventilation processes in place, are people still using CO2 monitors? It's like you've been talking daft. Get out there and get on with your life. Well, actually, we've still got this ticking time bomb that's underlying everything, which is really concerning. And that if it's not the public health messages coming into schools, then they're not going to do anything. And actually, something needs to be done if it's still serious, and if this thing is still going on, and we don't know when the repeat infections, because people, if it's not being monitored, they're getting this all the time, both staff and children. And so how it morphs, what it changes into is another issue. So if it is that serious and health people still think it is, then schools need to get that message, because it's not there now. The other thing that I was just going to ask about was the rehabilitation service and the ending of it. Would that affect other NHS providers, and would the extension of that service be in the long run a better efficiency saving?
Thank you for your question. So in terms of the provision and provider question, it is only HCRG who are commissioned to deliver that very bespoke long COVID service, and that nationally is ending in March 2026, so no other providers are impacted by that. I think the important thing, as I described before, is how that moves to a needs-based approach for if people are developing long COVID symptoms, how those are managed based on each individual's needs within the community. So that will be the offer. In terms of infection prevention control advice for schools, nationally the NHS no longer tests for COVID or advocates testing for COVID. So I think it's just really important that we encourage schools to understand what good infection prevention control looks like, but there isn't a specific ask at COVID at this point in time.
I'd just say, Chairs, that if you think it is something that needs to be acted on, then it needs that message to get back to somebody who might act on it.
What we can do is I'm very happy to link in with our infection control prevention lead just to come back with what is the advice for schools at the minute. Then we can be really clear, the panel can be aware, and we can make sure the messaging is correct. But just to echo again, the NHS no longer tests for COVID, so it's about that general advice, which is what we're looking for.
Just because they don't test for it doesn't mean it's not there. Yeah.
I think actually that's a really good message, and I hope that at least our infection prevention lead actually is also emphasising that too. Liz, and then Liz.
Well, I think nearly everything has been said that I was going to say, but I would like to follow up on one thing. Firstly, I'd like to say it's a shame that the national funding is stopping in March, and because I assume that was quite a bit of money that helped support people in our area. And you're saying that we're going to get a community needs-based support. Will that be good enough? I mean, I think it would be good to have feedback on this report as part of that. Who will be supplying the community needs-based support? I know you're saying there is not one type of long COVID, there are many, many types of long COVID, and therefore that has to be taken into consideration. But my question would be, is the community support service, is that going to be adequate, and what numbers are we talking about?
So I'm very happy to bring back in that report the numbers of prevalence for BAME, so you can see the trends since the COVID pandemic. Hopefully that will provide some insight into the number of individuals we are talking about and the age range of those individuals. So happy to bring that back as part of that update on long COVID.
Thank you. I think that would be really interesting to see. On my list now I've got Leslie and then Michael. Obviously if your questions have been asked, then you don't have to ask.
Yes, thank you, Chair. As a trade union rep, I have supported several people in my workplace with long COVID, and it is complex and it is difficult. Quite often GPs are not aware of long COVID and the symptoms. It's fairly new, so it's not an easy thing to go through. I had one Unite the Union member who was off sick for over 2 years, persistently wanted to come back to work, but every time they felt well enough, had a setback and then couldn't come back. Eventually they had to retire on ill health grounds, unfortunately. And I think you're absolutely right, and absolutely support it, Chair, that we do have a report coming here, but it needs to include the effectiveness of the interventions that have been put into place, because I know that particular person was on one of those programmes. And I said it's all new, so it'll be interesting to see what comes through that. There's a really big issue around public awareness and support for them that we need to be thinking about. And also, what kind of plans are there in place around adapting services as knowledge increases around long COVID. I'm not a scientist, but we did have the information at the time that this was going to increase and get worse. And for me, I think one of the things is around the funding. So, I mean, the hospitals are busy enough anyway. We were at over capacity, but plenty of money was put into the Nightingale Hospital that was developed at UWE, not used. We had PPE that was sent back because it was substandard, not used. So all of that needs to go into the mix on where we go in the future. And I think what we're hearing today, a number of these reports, they're quite short. There's a big issue there around health promotion work, and unfortunately the health promotion units were wiped out a few years ago, and maybe it's time we started picking them back up again and looking at them in a more coordinated way. And it's interesting what Becky's saying. It seems that the council's picking up quite a lot of that work. And as the council budgets get tighter and tighter, and we have fewer and fewer resources to deal with that, then this is going to become an even bigger issue in the future. Thank you.
And I think that question about, does this then become public health, what is the role of public health in ensuring that those public messages are going to the right audiences? I don't know, Becky, did you want to come back on that?
Yes, thank you. In terms of public messages around infection prevention and control, and part of the planning for winter, and working closely with the Integrated Care Board around planning for winter and the importance of ventilation and the importance of not coming into work if you're feeling poorly. Yes, we do have a strong role in that, and we send in our, I've made a note to check that our latest newsletter that we send out termly to schools includes some information around infection prevention and control in preparation for winter. So we do have a role, a strong role in that prevention and sharing of information space, absolutely.
It would also be interesting to see if it's the same messages, because I know, historically schools were very keen to encourage children who had colds, for example, to come into school. But obviously COVID is a different beast. Next on my list, I have Michael. I think that's the end of my list then.
I think my question's sort of been answered, but I just wanted to get an idea of the number of people that are affected by long COVID in Baines. We've been talking about it, but I have no idea what the number is. So once we get those figures and break down who then at least we know an idea of how big a problem it is. Thank you.
And I'll make sure we've got sufficient time to discuss this report in January. Right, we now move on to the ICB update. So this is the update from our Bath and North Sea, Somerset, Swindon and Wiltshire Integrated Care Board. Laura, do you want to add anything to what we have before us?
Thank you, Chair. If I may, just a couple of headlines, really. So the committee asked for an update on commissioning of all-age neurodevelopment pathway, which Lucy is going to give some headlines on in a moment. In terms of the rest of the report, I just wanted to draw your attention that we're looking for feedback on weight management services. That online survey actually ran until the 7th of November. We put it in there because obviously it was still pertinent with this batch of papers. We will bring that back to a future panel meeting. The winter vaccinations update includes some more information relative to the questions I think that we had last time. So specifically around, have we worked with NHSE on an ambition for each of the key winter vaccinations for specific cohorts? And the answer is yes. They have taken account of the WHO guidance on herd level immunity as well as national requirements. And those targets are worked through and shared with LA leads operationally. So I think it's fair to say that we continue to benchmark favourably, but obviously always more to do, never complacent in that space. So we can bring the vaccinations team to a future meeting. I have put that request to them and they have accepted, Chair. So when you think appropriate on your agenda, we'll make sure that's in our update report. Likewise, RUH, they're very happy. They have a new managing director there called John Palmer, and he would like to come to a future meeting. So if you could let us know when to schedule that in, we will do so. And then I think just on the question that we had relative to the Cabinet Member report on strategies across BSW, so that was specifically in relation to suicide prevention. I think, as Becky has already said, at this moment in time, we are working as an ICB. So although we are within the cluster with Dorset and Somerset, we continue to maintain our own BSW strategies where appropriate. So that includes everything that we're doing on things like medium-term planning guidance, for example. We are responding to that as a BSW Integrated Care Board. Clearly, as those clustering arrangements progress, we will consider and look at strategies and think about what does that mean and do we need to look at them across the cluster. But just to provide reassurance, at this moment in time, we continue to work as a BSW footprint within the cluster, if that makes sense. So if I may, Chair, I was going to hand over to Lucy to give headlines on the learning disability and autism item, which I think is the main one. Thank you. Thank you, Laura. So it's very timely to come to talk to you about this today. Some of you may be aware the National Independent Report into ADHD was published just last week. So for us in BSW, we are one of a handful of systems who've been selected to form part of the National ADHD Service Development Improvement Programme, and that means we are have the opportunity to influence both national policy and legislation. In terms of what we have commissioned, as the committee will be aware, we have commissioned HCRG to deliver an all-age ND pathway as part of the ICBC, the Integrated Community-Based Care Contract. That is a priority pathway, and that is expected to go live by the end of March 2026. As part of that work around ICBC, we did a lot of engagement with people with lived and living experience who have ADHD and or autism traits to understand what they wanted to see in a service. And what we heard loud and clear is people wanted a needs-based approach rather than a diagnosis approach. And that is exactly what the National Task Force recommended last week. So our work programme is in line with those recommendations. For the past 3 years, we've been working with HCRG around the Children and Young People pathway, again working with parents, carers and schools to understand what they wanted to see, and a new model is now in place. We've done a full evaluation of that model, and we've had really positive feedback from schools, parents and carers around the different approach, which includes self-referral into the service and a different way of approaching the assessment of a child or young person with those types of needs. As part of the change to the new model, the ICB undertook a commissioning exercise to look at the 5,500 adults from BSW who are on an ADHD assessment pathway previously commissioned with AWP, with waiting times up to 8 years. We reached out to all 5,500 individuals to better understand their current needs. And through that work, we identified different pathways for those people. Circa 600 of those individuals are actively on medication, and they have all been transferred to HCRG, so they receive a seamless service with no stop in their medication. There were a small number of patients under 10 who we felt needed to be expedited for their support and assessment, and those have also all been transferred. And that leaves around 2,000 people waiting for an assessment who are all also in the process of being transferred to HCRG. In the interim, those individuals and anyone seeking an assessment at this point in time can continue to use the NHS Right to Choose pathway, which traditionally and now has shorter waiting times. We have identified the need to make sure that people have that needs-based approach, but that people need to wait well, and we need to look at what alternative offers there are to that very traditional assessment model as we go through the transformational change. So the ICB has used £120,000 of service development funding, SDF funding, to support the third sector, our VCSFE partners, to offer an alternative in this space across BSW, and that offer will be going live in January. So that means that people can access support now to find their way in the world with neurodevelopmental needs, rather than waiting for an assessment. The other work that we've been doing is really focusing on making sure we have parity of esteem with this group of individuals compared to those individuals who are waiting for other elective care pathways, such as hip replacements, for example. So the National Task Force has supported us in making sure that we're really focusing in on how we meet the needs of these individuals. Happy to take any questions.
Thank you, Lucy. Any questions? Liz, and then Kevin. Oh, sorry, Barrett. Well, I actually didn't see who put the hand up first, to be honest with you. But I might take you first, Barrett, and then I'll work round the other way.
So, on the subject of seasonal influenza vaccinations, this year we have a mismatch with what is circulating and what is in the vaccine. And therefore, we may expect more cases of seasonal influenza and inevitably more hospital admissions. There's nothing we can do about that. But there are things that we can do going forward. And this is something I wanted to address, which is this: the importance of regular, annual, seasonal influenza vaccines. We are very focused on, please take your seasonal influenza vaccine. But we need to also incorporate in our communication that it is good practice to be immunized every year, because occasionally there will be a year when there is a mismatch between what is in circulation and what is in the vaccine. And therefore, you will have some benefit of cross-protection from your previous year's vaccines. Okay, having said that, moving on to seasonal influenza vaccine uptake, I think it would be really good for this committee here to ask, show us the evidence of how many people, your healthcare workers in the acute NHS hospitals who are eligible for the seasonal influenza vaccine have actually taken it up. Because the uptake, much to my surprise, considering their healthcare workers, considering their doctors and nurses and other staff in the NHS, the uptake of seasonal influenza remains low. And when I am on the other side, we try very hard to get those vaccine rates up, but they are shamefully low, and maybe we can do something about, look at your evidence, and what are you going to do about it?
Thank you. I think that's a really interesting point. Laura.
Yeah, so you're right, the uptake is lower amongst the workforce. That is something that we're seeing. We do have targeted campaigns, and we are trying to understand which of those professional groups within those different settings we might need to help understand the benefits of the vaccine programme. We can ask the vaccine team when they come back to give you some figures, because that data we do monitor, so we can bring that back. But you're correct, that is one of the issues that we're trying to overcome and have been for the last couple of years.
So, if I may just respond, let us not have the merry-go-round, because I've been in this seasonal influenza thing since seasonal influenza was introduced, vaccination program. And so that's about 25 years at least. And we revisit it every year. It can't be right. So can we sort of say, hold on, what's going on here? You're a healthcare worker. You really know what it's all about. And you know that the seasonal influenza vaccine is not going to give you influenza. It is a killed vaccine. You know, if you don't want to take your seasonal influenza vaccine and protect yourself and protect your patients, what other things may be going on with regard to your commitment to infection prevention?
I suspect that's the kind of question we might want to ask our infection prevention lead, and maybe they could also come on in January as well, if we have the paper then too. Lucy, did you want to add anything further? Oh, and actually, can I just ask, when that data comes to us, can we also have it broken down into maybe different sort of characteristics as well? Just picking up on the point that Michael made earlier around about BEMSCA and vaccinations. Right. On my list, I have Kevin and then Liz, I think.
Thank you, Chair. The neurodivergent pathway. First of all, how are you working with schools on this? And what implications do you think it may or might not have for IEPs and EHCPs? And do you see the pathways coping with the numbers that may come your way?
Sorry, Kevin, could you just say what the acronyms you mentioned
Sorry,
were?
I mentioned IEPs because that's our local school, that's individual education plans, but I meant EHCPs is probably a more common thing, the education, health and care plan. Sorry.
Thank you. So in terms of working with schools, we have the dedicated National PINS programme, which is around inclusion of ADHD and autism in schools. So within Baines, we have a selected number of schools which has been expanded now. We are in the second year, where those schools have dedicated support going in around autism and ADHD needs. And again, very happy to bring an update on the schools that are involved in Baines, including the increasing number that have started this year. In terms of demand and capacity, I think that's the exact findings of the National ADHD Task Force, which is we don't have enough capacity to meet the demand. And I think that's the society change we need around neurodevelopmental needs. So trying to identify early those children and young people as part of the EHCP process who have high-end needs and how adjustments need to be made, rather than a drive at the minute around people wanting to seek an ADHD or autism diagnosis. So the work we've done with HCRG, as I described earlier, is a front runner in that work. What it allows is those children, young people, where either there is parental and or school concern that need intervention, those children and young people are put forward for a formal assessment, which is expedited, rather than general advice that will be given to schools and parents about how to manage. The other piece of work that we're picking up linked to EHCPs and in general is working with parents and carers to understand what new normal might look like. So actually being clearer about when health professionals would worry about a child or young person who might display autistic or ADHD traits and what is normal now for that age range. So that's part of the work that will be coming in with the all-age ND pathway next year. But that's exactly the drive nationally, that if we continue to receive the level of demand for children, young people and parents wanting a diagnosis, we will never have enough capacity to meet that demand, which is why we're moving to this needs-based model, which will get to the heart as part of that EHC process around how each child has their needs assessed and then how those needs are best met.
Can I just come back on so do you see then the PINS programme as that every school will have it and that will be your way, if you like, of meeting those children's needs with the parent demands on getting something done? Or is the pathway in addition to that and the PINS programme just feeds into it?
So I think it's a combination of both. We have funding for PINS to continue for this year. We're pushing early for an earlier decision around next year. The national mood music is it's likely to be extended again with an aspiration it will be for all schools, but it's in combination with that all-age ND pathway. It's both of those things working together.
Thank you. Liz, and then Leslie, and then Joanna.
Thank you, Chair. Within the pathway, adult patients awaiting an autism assessment were transferred from AWP to HCRG as part of the ICB mobilisation. I just wondered, could we have more information on this? We seem to have a lot of information on patients with ADHD, but not autism. And I just wondered how many of these are people who have been diagnosed with autistic or autism or awaiting an autism assessment. How many are on a waiting list? What length of time have they been on this list? Is it longer under HCRG than it was before? And also you've said patients waiting ADHD assessment and ADHD assessment have all been contacted. What about those with autism? So I think I'd really like a bit more information on autism, please. Thank you.
So, as I alluded to earlier, with ADHD we had 5,500 people waiting. With autism across BSW, there were under 2,000 waiting, and all of those have transferred across. So it's a smaller number, but still a large number. We're working with HCRG on the reporting. They've already started seeing those individuals. The autism waiting time with AWP wasn't as high as 8 years, but for a number of patients it was up to 5 years. So what we have commissioned will hopefully be a shorter wait, but we've worked through the mobilisation process. So all of the people who've been waiting for an autism assessment have been contacted by HCRG to say, we are now the provider of your service, this is what you can expect. And the all-age ND pathway I discussed is around autism and ADHD being brought together, because a number of people will have traits of both conditions. So what we want is that all-age approach, reduction in transition and cliff edge pathways, but something that looks at everyone's neurodivergent needs as a totality rather than an individual diagnosis.
Could I do a supplementary question, please, Chair? Did you say years?
5 years.
5 years, sorry.
So
rather than months or...
No. So yeah, the ADHD waiting list was up to 8 years and the autism waiting list was up to 5 years.
So what do these people do in the meantime?
So that was my point earlier about waiting well support, because what we are doing with the new all-age ND pathway is reaching out to people about how they can find support without needing a diagnosis. So that includes support with how to work within your family unit, how to link in with higher education or schools, and how to link in with your workplace. Things like what reasonable adjustments you and others can make to help improve your working and daily lives. So it's that waiting well support. The future will be, you won't need to wait for that formal diagnosis because the whole national model is changing. But the minute, it's about that waiting well advice and support.
Leslie and then Joanna.
Yes, I want to pick up first of all on the all-age neurodevelopment pathway, because I think this is hugely important. The fact that it's shifted from needing a diagnosis to looking at what needs are is hugely important. You know, we've seen and we've discussed this before, the number of people in the population who are somewhere on that neurodivergent spectrum, including autism, of course, is growing. We can see that through the people needing EHCPs, not just needing them but not getting them. The system can't cope with the volume. And if you look at people in prison, at least 50% of them, and probably more, are somewhere on that spectrum. Surely it's got to be cheaper to support people correctly in the first place and bung them in prison, lock them up at whatever cost that is. So this is really a really welcome move, and it's fantastic that you managed to find some money as well, that's going into the support services while people have to wait these extraordinary lengths of time to get any support. What I'd like to see, and I presume we'll get a report on some of the effectiveness of this in the future, but how is the new system going to be promoted, and what's the entry points to it? How will the voluntary sector be monitored to make sure that they're being effective as well? And how about schools and GPs? What support is going in there, and what training is needed there? Thank you.
Lucy. Thank you. So there's a huge amount of promotion work going on at the minute with all agencies, including schools as part of the PINS programme we've discussed, and also within primary care. And as an ICB, we have to publish an NHS Right to Choose statement that's on our website that also provides advice about where people can get support. So working with HCRG on the co-development of the new pathway going live by March, that includes a communications plan. And importantly, the new pathway, which is what we've done as a precursor for children and young people, it doesn't require a GP referral. People will be able to self-refer, and then there will be a review of what their needs are. So that communications plan will follow. But at the moment, for people who are waiting, they can use the NHS Right to Choose pathway, and we are supporting people to do that.
Thank you. But picking up on Leslie's point, I think maybe we'll have a larger report on this part in due course. Joanna and then Barrett.
Thank you. I'm just going to pick up first on the flu influenza. My husband has lectured me for years about getting one. I only had one this year. I have made sure that my children have had it as well. I do think there should be a cross-party press release on people having it and why you should have it, because I always just used to think it was for old people, and we aren't sold the story that it should be for everyone, and that is the message that goes across the board. I certainly have read into it what the problem is this year and have made sure that everybody I speak to, I say go and get a flu vaccine. There should be better press on this across, and that should come from you guys to the council to make sure it gets out. Then picking up on neurodivergency, thank you. It's fantastic to hear that this piece of work is moving forward. There will be a huge number of people who will be pleased by that, but my concern is about the process. We have large numbers of young people who do not have EHCPs in place, who can't seem to get EHCPs in place, who therefore then aren't supported in schools because they don't have EHCPs in place. So when you're doing this work, how are you deciding which group of people go first? Is anybody under the age of, let's say, 10, 16, are they your priority? Because if they aren't in the system now and supported, then going forward, they are the ones that are going to have most impact. We have to make choices with money, so therefore if I'm in my 50s and I've got through to this far, of course I need to live well and be supported, but how are we supporting those who are young right now, who are in this predicament? And we know from the council's numbers that we don't have enough people to support the ECHPs that we have been asking, that have been asked for. And then I have a follow-up question too.
Do you follow up now?
So firstly, just on the flu, would agree we can never do enough communication. So if there's an action we can take, our IP&C Infection Prevention Control team have been working with partner agencies around staff messaging, but there's always more we can do, so we can certainly take that back. In terms of how people are prioritised for a neurodevelopmental assessment, it's based on need. So what we traditionally see is there is a weighting to children and young people as their needs present in a greater way. So there isn't any defined rules around it. What we do, as we do with a number of NHS services, it's based on need at the time of presentation. But what we can see and what we are looking for with the new pathway is a continuation of that approach. And I think there's something, isn't there, which is not within any individual organisation's gift to change, but where we see quite often, for example, schools or employers saying we need a diagnosis before we can make reasonable adjustments, we're going to have to change that thinking because not everybody needs a formal diagnosis. So this is a huge piece of work that's going to impact on lots of ways. If we get this work right, the people who need the assessment and need those changes will be prioritised, because that's what the all-age ND pathway is aiming to do. And other people, including adults, will be supported to self-identify and then signposted into how they can get support without needing that assessment process. So by the nature of that work, it's really focused in on that early intervention and prevention agenda, which is why we started with children and young people.
I'm just picking up with Laura. An issue that's been raised with me is about termination of pregnancies and what data we have on what's going on with the changes that have been introduced in terms of the Abortion Act 1967 and pills obtained, and how we are supporting young people in this process. Do we have any data that you can bring back next time on the services that are offered, where people are supported, and are they getting the right services?
Councillor Wright, if I can ask if you could send us that question, we'll make sure it gets to the right people and we come back with a written response and a verbal if needed.
Right, I've got a few people who want to come back. So I've got Barrett, Leslie and Kevin, and then me. Where did I start? Barrett and then Leslie.
On the subject of what Councillor Wright has just said, I've always advocated, but it would be better coming from ICBs and others, which is this. If you're not eligible for the seasonal influenza vaccine, please nevertheless immunise yourself. It only costs £10 and it is far better than being ill for a month and maybe even damaging your lungs forever. I think we miss a trick, and I agree with you, Councillor Wright, in that we focus on what we need to focus in the health sector, but actually spreading the message wider is flu can infect everyone, anyone. We can protect who we can protect with the costs that involve with giving the vaccine. On the other hand, you can also protect yourself by paying the £10 and getting yourself vaccinated if you're not eligible for a free vaccine. I wasn't going to ask that question, but I just added it. My question is this about neurodiverse people, which is on the same lines as what we talked about with dementia. And that is, and please bear with me, this is not my area of expertise, but I feel empirically that whilst we are dealing with an increasing number of young people diagnosed with neurodiverse interventions required, are we doing anything with regard to where is the evidence of what are the causes of neurodiversity? And is there something we can do with regard to, on the same lines that what Director of Public Health Becky said, which is, healthy living, healthy diet, avoidance of ultra-processed foods, in pregnancy, earlier on. I don't know, so I'm asking, should we sort of have a little bit more focus on, are there any determinants of a healthy mother equals a healthy baby, or am I misinformed? I don't know.
Lucy, do you want to come back on that?
So I don't think we know the answer to that question.
Yes.
I think what we're working through is it increased prevalence or is it increased presentation? And we don't know that. And I don't think across the world we know that internationally. There's various bits of research, but it's not known. So I think the early intervention and prevention piece I'm describing in this space is how we identify someone as having autistic or ADHD traits and how we support them to live in the world with those neurodivergent needs, rather than any more traditional prevention, because we just don't know at this time.
Yeah. No. Thank you. Leslie, Kevin, and then myself.
Yes, I wanted to pick up on one or two other things. So, the Weight Management Services review, what plans exist to incorporate newer weight loss treatments into NHS pathways? On the winter vaccination update, the figures that we looked at before was there's a very high vaccination uptake in BSW. So are there some lessons that can be learned from that could be shared? And picking up on the issue in hospitals, the take-up does seem to be lower. And again, we're not quite sure why that is. On the community pharmacy services, how is public awareness of Pharmacy First being promoted? Thank you.
I'll work through the questions backwards, if I may. So in terms of Pharmacy First, that's obviously national campaigns, and clearly we adapt those locally, and we work closely with public health colleagues and others to make sure that that is far and wide. And I think early indications are that campaign has been successful, because we are seeing people access services through pharmacy. So we can come back with an update on some of that information from our primary care colleagues, which now obviously also includes pharmacy, as you heard last time. In terms of the high uptake, low uptake, lessons learnt, I think we've agreed that we will bring that back
around vaccinations in the next update. And then, excuse me, finally, around weight loss, yes, that weight management service does include the weight loss medication. That is being looked at as part of that pathway. I'm very happy, again, to ask colleagues that have got the specialist knowledge to come back with that information alongside what the outcome of that online survey has told us.
Thank you, Laura. Kevin?
Thank you. Just coming back on the EHCP bit, have you had or are you having discussions with the council SEND team and things around the support bit? Because often parents and schools indeed with no funding and no resources often push for EHCPs because it's a funding mechanism. So what, if you like, is being talked about around the replacement of that, or how that might be transitioned a bit if you are now going to a more nuanced approach with meeting needs?
So I think that's part of the needs-led approach that we're looking at locally within BSW. And as I described at the very beginning, we are in the fortunate position to be part of the national programme to influence policy change and legislation change. And that's one of the things we've raised in that group. We are still awaiting the SEND reforms as well to understand what that future looks like around EHCPs. So I would say it's a continued conversation at this point in time.
So my questions are around waiting well, and I think I was particularly struck by this phrase about the new normal, and I wondered whether or not that then is going to change what maybe society sees as normal, and therefore whether or not the thought process behind that is somewhat about reducing then the expectation of an EHCP, and also around maybe even the diagnosis of ADHD or autism or any other neurodivergent condition. And I'll ask my second question, which is completely unrelated, which is around barriers to vaccination, and I suspect that this will come up in the bigger report that we're expecting, because I think Barrett referred to the cost for a vaccination being £10. Sadly, it is not. It's at least double that, and it depends on where you go as well.
Depends where you go.
Oh, it depends on where you go, absolutely.
I was very surprised, but the price is often £20, but you can get it for £10. I know, because I looked. So it really is a case of where you go.
Absolutely, yes. So I just wondered whether or not that was, whether or not it's proven that this is, the price is a barrier to greater uptake. Did more people have the vaccinations when they were free, I guess is what I'm putting to you. And then I have a third question, but which is, I suppose I could make a link, which is around community pharmacies. I think there was some report of, listed a number of pharmacies across the country that were expected to be reopening. I think that's not entirely the correct phrase, but you know what I mean. But I don't think there were many on that list that were actually in Bath and North East Somerset, and I wondered if either you had an update or if you could provide an update sooner rather than later.
Thank you, Chair. So on your first question around ADHD and autism, absolutely one of the key bits of work is going to be managing expectations of parent carers and professionals as well, because we are going to move away from a diagnosis model, and that's the work that we're starting. So we've done lots of engagement with parent carer forums, including colleagues with the Bath Parent Carer Forum, to start those conversations. And as we develop that all-age pathway, there's a number of workshops being held, including people with lived and living experience. So I was talking to a group of head teachers the other day just to start that conversation about that change in expectations. Just on vaccines, and then I'll hand over to Laura around community pharmacy. The majority of NHS staff are entitled to free vaccinations, just around understanding those barriers. But in terms of the wider public, it does vary in cost. So I've been nagging my family in Bath to say, please get your flu jab this year, it's going to be a really bad year, and I've had relatives pay anything from £7 to £18. So there's a question we can take back just to understand that price point, and is there any national guidance on it?
Thank you, Chair. And around the community pharmacies, this was around the Jahoots chain, which I think had been raised here previously, concerns around some pharmacies that are seemingly temporarily closed, but temporarily being a very long time. So it's now become apparent that that is a national issue. Many of you will have seen that, I'm sure, being reported in the news. We are, as an ICB, as strategic commissioners, using all of our commissioning levers that are available to us. As we've rehearsed here before, the way in which we look at what the needs of an area are is done through the pharmaceutical needs assessment alongside with our public health colleagues that lead on that. And that's not in our gift to change the parameters of that assessment. So that assessment is the one that would say whether there's a temporary closure and therefore that there is no gap technically because a service is still commissioned where there is a temporary closure. So whilst that might seem counterintuitive, that's the reason. So what we're trying to do is understand where those pressure points are. So thank you to the committee because you have highlighted those with your local knowledge. And as I say, we are using all of the avenues available to us to try and resolve those issues. There has been movement on a number of them. I'm not able to say more at the moment. Some of this is commercially sensitive, but we will provide an update offline.
Thank you very much, Laura, and thank you, Lucy. And I know that you were hoping to leave, so I will let you go. Oh, hang on a second. Could you just wait for 1 minute? Varrick's going to wants the last word.
I have a question about community pharmacies, and it's on the angle of conflict of interest. So when I see a patient as a GP, I look at them, I make a diagnosis, and I say, it's fine. What I want to know is, you see, an ICB has, because they can't afford general practitioners are moving patients towards, going to see a pharmacy for minor ailments and things. Is there a system put in place to monitor that how many people came to see a pharmacist and was sold a over-the-counter other medication? I think what I'm getting at is, you see, a pharmacist's interest is in selling you something, an over-the-counter product. And I want to know how many people who go to a pharmacist end up with an over-the-counter product. The over-the-counter product may be needed. On the other hand, it may not be needed. But if we don't know that actually by sending patients to pharmacies also results in them spending some money which may be necessary or may be totally unnecessary. My bit that I'm asking is, are we looking at this? We've sent people, go and see the community pharmacist, but are we then saying, hold on a minute, what did the community pharmacist do? Did you inevitably end up with a over-the-counter product? And was that over-the-counter product necessary?
Okay, I suspect that our ICB reps will not know the answer immediately to that, but I'm sure they'll be able to take it away and at least give us some sort of,
What I'm getting at is, we are doing what we're doing because we haven't got enough money. So we said we can't employ GPs, but we'll send people to pharmacies. But the thing to be aware of is, hey, hold on, they're commercial. Their interest is to sell you over-the-counter items. And then I feel, as a councillor here, I want to ask that question. Does this entail ordinary citizens who know nothing about, whether they need this product or not, are being sold items over the counter? Are we looking after our people as well as we can?
And perhaps maybe what we could do is we could also have a look at the role of pharmacies and pharmacists within our communities as well. Laura, do you want to respond very quickly?
Yeah, very happy to take that back to our pharmacy teams. What I'm hearing is we're looking for the assurance, aren't we? So how do we know what people are being referred for, what the outcome was, what metrics we've got, and how we're providing assurance? We'll ask the team.
Yes, thank you.
Of course.
Thank you. On that note now, you may leave the room. Thank you. Okay. So our next item, item 9, is Adult Social Care Residential Services Update. Alison, do you want to give us any sort of further information to that we have in our report?
Yeah, I'll just briefly summarise that this paper is providing an update on the residential services that we've been providing since 2020 after we took those services back in-house. It covers 2 care homes and 5 extra care housing units, and it really gives an update on where we are. I'm going to hand over to Claire Thorogood, who is the manager who manages these services, to provide a little bit more information, and I'm sure she'll be able to answer questions as well.
Thank you, and welcome, Claire.
Thank you very much, Chair. Alison's already introduced and said we're going to concentrate on residential services, and we also have with us today the Head of Service of Residential Services, Anne-Marie Stavard. Just to start off, I'm just going to do a few highlights, just a moment or two before we take questions. The CRCs, Community Resource Centres, we have 2. One's based in Twerton, the other one is based in Midsummer Norton. Cleve Court is a 45-bedded unit, and Coombe is a 30-bedded unit. And of course, we also have the extra care schemes, and Alison has said there's 5, and those whereby we are able to give 24/7 dedicated care to those residents as well, and they also enjoy communal spaces, and daily meals are available, and those 5 services are spread across the Baines footprint. We also have some step-down beds with our extra care. That's delivered in partnership with Curo, and this is really important because it offers some short-term accommodation with care for up to about a 12-week period. That supports individuals with hospital discharge, and of course it's an opportunity for reablement activities. This is aimed at people regaining their independence whilst we clarify their ongoing support needs during their stay. At the moment, we're very pleased to report of the 221 beds we have available, we have a very high occupancy of 97%. We're thrilled at this, and this is comparing favourably to an 85% occupancy for other care homes within Baines. Just to touch upon a few workforce points for panel, we have a stable management team for Coombe and Extra Care, and we have successfully recruited a new registered manager for our Cleve Court care home, and that person commenced in post back in September. We employ 240 permanent staff. It's a big service. In addition to those 240 staff, we have a team of bank staff. That's about 213, and that allows us to reduce our reliance on agency and utilise that pool of individuals across our suite of services. We currently have 23 vacancies. In the main, I did look last week at how we compare nationally. That's about 9.5%, whereas the national trend would be about 7%. But we are seeing really good improvement trends in our staff retention over the last year. So that will help us manage that vacancy factor in a more appropriate way moving forward. That staff retention has improved. We've only had the 16 leavers from April to September this year. So that is moving in the right direction. And we attribute that to our terms and conditions and the good level of support that our staff receive in our services. Staff turnover in the care sector nationally is actually 24%, and we are operating at 17.5% at the moment. And of course, we do monitor sickness absence, and we have good quality ongoing support mechanisms in place for staff, whether that be return to work, additional supervision, occupational health referrals, and more emphasis now being placed upon wellbeing action plans and stress risk assessments for managers and frontline care staff. We have a very comprehensive mandatory training offer, and our training compliance rate is 88%, and all managers are encouraged to undertake their apprenticeship at level 5, whereas some have started at level 4 and worked up to the level 5. Staff teams are incredibly proud of the services that are delivered to the residents of Baines, anything from kind and compassionate care to our residents, even our offer of respite and our end-of-life support for residents and families is often shared and communicated amongst the management team and up to Suzanne or other executive directors as points of comparison throughout the year. Quality assurance and regulatory compliance, as you can imagine, in regulatory services, we spend a lot of time and effort on this. We are indeed on an improvement journey. And the current CQC ratings, which are from 2022, are in the report. And I've also included those in terms of the different domains of the rating across the 5 domains. We are good. We are CQC rated good within our extra care, and we are requires improvement with the 2 community resource centres. So, a part of our continual improvement journey, we introduced last year some unannounced mock inspections, and that was both care homes and across the 5 extra care suites, and we utilised that feedback. Because CQC inspections are several years apart, we thought it was really important to have that impartial, independent review to make sure that the things we are doing for our ongoing quality and continual improvement are focused on the right areas. That has been well received by staff, and we are about to go into a new round of those in the next week or so. We conduct annual quality assurance satisfaction surveys, and we have included in our report to panel some examples of the recent feedback and compliments that we've received only recently. That is not for the whole year. We undertake commissioning and quality assurance reviews. Baines commissioners come out and visited both CLCs in July, and we utilise that feedback as well in terms of adding to our comprehensive service improvement plans. CQC did choose to conduct an unannounced inspection of Cleeve Court. Unannounced is not uncommon. All care homes have an unannounced CQC inspection, and that inspection ran from July, and they kept the assessment open through till the October time. It was expected. It was in the 3-year window for an RI service, and we have been asked to return our factual accuracy upon the draft report, which Suzanne, as the nominated person, received, and Suzanne, myself and Anne-Marie reviewed that and made the submission on the 14th of November. So as it stands today, that report is pending. It is not publicised. Once we do have publication, Chair, it would be really good to come back and update panel on the ratings, the findings and the work that we are doing in response to that CQC report alongside the other improvement activity that we continue to do. Thank you.
Thank you very much, Claire. So this report is for noting, but I will take any comments or any points that might want to be just explored a bit further. Liz, and then Leslie and Barrett.
Thank you. I'd like to ask 2 questions, one about space and one about staff. And I must admit, when I saw that the occupancy rate was 97%, my immediate reaction was, oh, there isn't enough space for future residents, whereas you're saying, actually, it's great that we're so full, because obviously the money's coming in and we're able to support and our self-supporters support others, etc. And we've got money coming in, so that's a good thing. So I would then ask you, so have we got more space if, more people want to use our 2 residential homes or our 5 other homes? Have we got enough space within this? It's mainly the 2 residential homes, I believe. And my question about staffing, I mean, it's good to see that our turnover is a lot less than nationally, because that is a big problem, isn't it, with carers. But there are 23 vacancies, and we're still using bank people. Now, as an ex-teacher, I assume it's like supply teachers, so you pay more for them. So we're using bank members as well as our permanent staff, and we still have 23 vacancies. So is this costing a lot of money? And obviously, what else are you trying to recruit more? I'm sure you are, but what are you doing to try and recruit more carers? Thanks.
So, in terms of our space, like I said, we're very pleased we are at 97% occupancy. We do at times have a little bit less. There is an ebb and flow to residency within our homes. One thing we are exploring isn't additional care home, because there's space in the market. Yes, we have the 2 care homes. There is space in the Baines market, but we are currently exploring, at the early stages of exploration, it even down, with the transfer and transition of some of Guinness's step-down flats into additional extra care, because that really supports our Baines independent living strategy, and individuals get the benefit of the 24-hour wraparound care and support and communal space, and emotional and well-being support alongside living as independently as those individuals can. So your comments are absolutely the right ones. At the moment, we are exploring the expansion of extra care in the first iteration. Okay? I will take straight away, if you don't mind, the question around agency and bank. So we utilise our bank effectively so as we are not out using expensive agency. So bank staff, in the main, are actually our own staff who wish to then take on additional shifts and hours. So they have a permanent contract, and they can also then have a bank contract. That's wonderful, in my opinion, for equity in the care market and the workforce. It is also super helpful for the continuity and the quality of care. We have some bank staff that only choose to work as bank carers, and that suits the flexible approach that that individual has chosen. But bank is used effectively so as we do not have a continual draw on very expensive agency. That's the step change. It's like our own internal agency, if you like, is one way to explain it. And we've seen a 17% increase in bank utilisation before we go out to agency. So that agency spend we monitor very, very carefully each month across each of the services with our finance business partners.
Thank you, Claire. Leslie, then Barrett, and then Kevin.
Yes, thank you for the report. I mean, it's a good news story again, isn't it? And I think we shouldn't let that go past us when, you know, improvements are being made in fire safety and infection control, manual handling, that the service is person-centred care, there's activity programmes and nutrition. It's really important that that's happening. And the other good news is that retaining staff and the turnover is far less than it is elsewhere, which is a huge thing to achieve. And I think, you know, the Michael West research shows that if you treat staff appropriately, although he's referring to the NHS on the figures he's used, but then people's performance will improve. And if their performance improves, then the service improves for patients and mortality rates go down, which is a whole interesting piece of research. So I mean, well done. It'd be good to see a report coming back at some point in the future to see, you know, how well it continues to go. I think recruitment's always going to be an issue. While the pay is low, that it's always going to be problematic. I'm just wondering what impact of wellbeing initiatives had on staff morale and turnover. Has that helped any? I think that's it really, because you've been very thorough in what you've given us. Thank you.
Okay, Claire.
Thank you. In terms of wellbeing, we monitor that very carefully. So I've alluded to the reporting, occupational health referrals, the stress risk assessments and the wellbeing action plans. And what we do is we have a dedicated HR business partner that works to support the service, as you would expect. And each month we look at informal routes to support staff, whether that be an increase in supervision, you know, additional training, additional practice observations, and making sure that we utilise all of the wellbeing support that's not just available within the service, within the care service, but actually as a Baines Council run service as well. And I think that alludes to our improved retention rates, if I'm wholly honest with panel. Staff work hard across the services to retain and share their best practice, but making sure that whilst we're doing so, utilising any assistance programmes and utilising the learning that's taken from that. So we have about a 10-step area whereby we look at the wellbeing support that's available and the take-up of the wellbeing support. And a lot of that is, of course, formal, but we make sure now that we reflect that in staff supervisions so as we're having ongoing conversations about wellbeing. What the teams increasingly do across the services is when there are difficult moments, because of course, you know, care can sometimes be very emotionally and physically demanding, spending time doing reflective practice as well, whether that be with the registered manager or with Anne-Marie as the head of service, and we have brought in at specific times as well some counselling support for individuals around wellbeing. Other things we've done in the year previously is look at the change of shift patterns. Lots of staff had said to us that working shorter 6 or 7 hour shifts, there was a preference to have the choice of a 12-hour shift or a 6-hour shift to give longer points of recovery and have a 3 days on, wasn't it, 4 days off approach, and we've looked to do and implemented that sort of activity. So wherever we can, we use the formal processes that are available to us, as well as what I'm referring to as the practice-led processes, where there's a lot of opportunity for reflective learning within the services.
Thank you, Claire. On my list, I've got Barrett and Kevin and now Michael, and I think I'm going to finish my list at that point. So, Barrett, you're next.
So I wanted to mirror Councillor Mansell's positive comments. It's good. We're doing things and achieving things. I just wanted to ask about your unannounced visits. Very good, good. Can you just tell us, what does it look like? In other words, you know, do you arrive there with people who are expert in the matters, who are knowledgeable about what to look for, etc.? And then one more thing, and I know this is difficult, but it just occurred to me, is it also depends on when you turn up, meaning what time of the day, because sometimes certain shifts, especially at night, etc., may be underpowered. And I'm just curious to know that, you know, if you turn up always at 10 a.m. unannounced, you may get one result. But if you were to turn up at 9 p.m., and I know it may not be easy to turn up at 9 p.m., but I'm just curious to know. But step by step, take me through what does your inspection look like, and then we'll ask the other questions afterwards.
No problem at all. Sadly, I was out of the country for our inspection, so it was led by Suzanne and the head of service. But if I give you the general overview, and then maybe Anne-Marie, you can step in and provide some more of the detail. So it happened mid-July. They did come during the day. They don't tend to do an announced inspection through the evening period, but your point is very well made. They came, they did a site visit on one day, and then they returned the following week to do another on-site inspection. Upon point of arrival, they would always touch base with the registered manager, okay, of the care home, alongside the head of service, and of course then they would discuss their themes. Their themes were the two areas of requires improvement, so safe and well-led, because that's what was required improvement. So they didn't look at all 5 domains, and they will ask you scene setting, targeted lines of inquiry, and of course then go out and test those by speaking with our residents, speaking with staff, triangulating with key processes and documentation. Now, what happened on this visit, it was sort of the new methodology whereby it's not that the visit is extended, the on-site visit is one element of the inspection, but then through those lines of inquiry, you have the opportunity to continue to work with that lead inspector to provide additional evidence, or in our case, we had a bit of an action plan and we worked through that with the inspector. That's why that window in methodology was open from the July through to the October period. In that time, so drawing upon what they'd seen on the days they were in the service, our response to the action plan and submission of further evidence, we had an initial feedback session on the 6th of August with the lead inspector. That was positive and favourable. They commented on the management and the staff's willingness to go through a thorough inspection and take away learning and practice and take forward an action plan that they could see demonstrable improvement. And thereby we did submit, I think, 2 additional action plan updates to the lead inspector before Suzanne, as the nominated person, received the draft report. So that's the mechanism by inspection. Is there anything you want to add in terms of the experience on the days, Anne-Marie?
Yeah, sure. Thank you. So it is normal practice for CQC to arrive unannounced to a care home. Within an extra care scheme, they do tend to give a little bit of notice in case a manager is not on site. But certainly with all the care homes that I've worked with, the CQC do arrive unannounced. It was a very interesting experience. I've been through a number of inspections. This was very positive. It was very open and honest on both sides. The inspector gave feedback regularly throughout the process. We also had an expert by experience who specifically met with the residents, with carers. They also followed up with a number of calls to family members and relatives and professionals after the visit. So all of that has fed into the inspection. Thank you.
I don't work in banks deliberately, okay? But when I'm investigating incidents and outbreaks and things like that, sometimes I will pick up the phone and call CQC. Can people like, okay, I'm talking about myself as consultant communicable disease control, okay? So can, in our local authority, the same apply, whereby somebody like my equivalent picks up the phone and says, I'm repeatedly investigating norovirus outbreaks, etc. I think you need to go and visit this place. Does that happen?
Yes, it does. Yeah. For our care homes, alongside all other care homes. Okay, so that's something that we refer to as a CQC notification. Okay, and any professional, any family member, a concerned individual is of course and encouraged to make sure that those things are fed back. Yeah, and standard practice would be Suzanne is the nominee. If one of those goes in on behalf of one of our homes, Suzanne is the nominee, would receive that communication from CQC. That would come out to us within the service to make an appropriate response to go back and give CQC the assurance.
So, following Barrett, I think I've got Kevin and then Michael.
Thank you. Well done on the positivity that's coming through. I hope the report, when we do see it, will be green. Can I just, one quick one around the age of the staffing, which seems to be a demographic that head teachers fall into. Are you doing anything on succession planning and things around this?
Absolutely, we are. So we have a Baines workforce strategy, and within that we are developing a very specific workforce strategy for our services for exactly that reason. It is a demographic that is known, and it's a demographic that's actually repeated across the care industry. We have a dedicated HR recruitment advice and guidance partner that we're able to work with, and we do this alongside some of our organisational development activity. So one thing the services have done over the last 18 months is offer and work in collaboration with Bath College, make sure we have student placements for those individuals that want to, that are already doing their level 2 or level 3 in social care, to come out and develop their experience of a competency within the skilled sector. We have apprentices working within the organisation, and we support that career progression as well, so the grow your own in terms of going from a care worker to a senior care worker, through to a deputy or a service manager, through to a registered manager. And for the management aspect of what we do, we make sure that we are utilising the level 4s, the level 5s apprenticeship where we can, so as there's that really clear management. The bulk of the activity, though, which I'm sure you're referring to, is with the frontline carers, of course. So targeted recruitment campaigns we go out to do, recruitment fairs, we invite people in to view the services, but yes, there is more to be done, and there's more that we do need to do as an employer in Baines to make sure that we are equipped over the coming years for that changing demographic. Retention, of course, really supports that, because we would want to retain and support staff to move through and progress in roles that are available to them. Some of our staff even choose to progress within the different services as well, which is very helpful. But more does need to be done, and that is something that when we update our self-assessment, which I've spoken about in the new year, that will be a very, very key theme about the work that we're going to do to shore up our workforce for the future.
Right, Michael, I think you have the last question on this one.
It's just a quick one, really. As well as wanting to visit Coombe, I'd be interested in also potentially visiting Green Acres, and has been within my ward, and just getting a much better feel about all the different services, because this is a very thorough, very positive report, and I'd just like to be able to see some practical examples of that as all right, if I can.
You can visit 3 services when you come out there. There's 3 services co-located. So Green Acres is our extra care facility there. Of course, you have Coombe as the care home, and it's within the Coombe care home that we now have the OT assessment centre. So we can get that organised and supported for you, and it's a nice opportunity. You can view the footprint, view the services, meet some of the staff, and look at some of the nuances between those 3 services that are co-located in that one area in your ward. Yes.
Oh, Suzanne.
I just want to manage expectation around the care homes and extra care, because remember, we invested 2.5 million when we took these services back, because there was so much work to do. We had an agency bill of 3.1 million then, across the care homes and the extra care, and we had a lot of work to do around digital care planning, making sure the quality of care was good, making sure that we're at the retention rate that we're in now. It's been a journey, and when you run services internally, because our staff are well paid and they've got good terms and conditions, good pensions, it has taken some time to get us to this position. So I just want to manage expectations around that. It's a lot of work. There's a lot of support from Cabinet. There's a lot of support from the corporate management team, from Claire and Anne-Marie to get us to where we are now. But it does cost when you run your own services. So I just wanted to make you aware of that, because we've been on a journey to get to this level of improvement.
Well, I'm not sure that's managing expectations. That sounds rather like you're raising our expectations to be even more. Anyway, but I'm sure we can pick this all up in even more detail. You said, I think in one of the recommendations, or you asked for us to agree that you would come back. Do you have some idea of when that would
Sadly,
be?
Chair, timescales with CQC publication are not my forte. So the moment that report is publicised, we will of course brief the lead member, and I will make sure then that Suzanne is able to agree how quickly that report can come back into panel, so as we can, like I said, give the overview of the findings, explain the rating and the methodology, alongside then the more important aspect of these are the things that are being done and the improvements that we have made to date. So as soon as we have that in, we can make sure we come back to panel quickly.
Okay, so we're
It's
probably...
a waiting game. We don't know when they're going to
But in
choose.
the next, say, I don't know, the first half of next year, as opposed to in 4 years' time.
It will be within the first half of next year. If you ask me what week it might be before Christmas, I'm not able to say. That depends on the factual accuracies. So the moment we know that, Chair, we can make sure we're booked onto the agenda to come back to panel.
Thank you very much, Claire. So are we, as a panel, happy to note and happy to expect a future report? That's lovely. Thank you. Right. Now the next item on our agenda is modern slavery. I'm very sorry, Sam, you've waited, Samantha, you've waited so long, but we will ask Alison to introduce this item, and thank you for the slides that I think we've had a look at, and obviously it'd be nice to put a little bit more meat on the slides, as it were. Alison.
Okay, thank you. Yes, I think this report was requested and it's really helpful for Samantha to put it together. It's quite high level, and there isn't an enormous amount of detail on BANES as such, but I'm assuming that you may be able to answer some more detailed questions in relation to Bath and North East Somerset, which I guess people will probably want to know more about.
Yes, Samantha, do you want to say anything, or do you want us to hear questions?
I'm happy to take questions immediately if that's suitable, because I realise we're short on time.
Sorry, Samantha, would you like to introduce yourself?
Of course, I'm Samantha Jones, for those who don't know me, Inclusive Communities Manager here at the local authority, and that means I have 3 portfolios: equality, diversity, inclusion, refugee and asylum seeker resettlement, and community safety. So modern slavery and human trafficking is a very small part of community safety portfolio.
Right, so do we have some questions? Liz, and then Paul.
Right, thank you for the report, but I would like a little bit more detail, actually. And I just wondered, in the modern slavery that has been found out in Bath and North East Somerset, which areas of work does it actually include? Do we have any idea? And the second really important question, what can we do about it? Now that we know where it is, now that we may know where it is and who's doing it, what can be done about it? Would it include residents, customers, business people, employers? So just a couple of extra questions, just to get a little bit more detail. Thank you, Sam.
Sure. In Bath and North East Somerset, the areas of work that we've uncovered modern slavery, in no particular order, I've jotted them down, are care work, and we're participants in the Southwest regional research at the moment. James Sawford, Adult Services, is leading on that for us. Slavery in supply chains for care work is a particular area of interest right now. Beauty and nail bars. We've got a history of uncovering a number of particularly women in nail bars. Hospitality is another area, not so much restaurants and cafes, but hotels at the moment. So Unseen, that you saw in the document, who are our national leaders but happen to be Bristol-based, have approached Bath and North East Somerset to work with them on the first project of many of a lottery-funded activity to look at hospitality and modern slavery and human trafficking, to try to determine how we can intervene for people who are already working in hotels particularly, where their touch points are outside of work, so that we can reach victims while they're away from their employer or handler. Car washes and anything to do with the cash economy is vital, and in the beginning of our slavery identification work, which is probably, I don't know, 5 or 10 years ago now, car washes were where we started. People who are slave handlers are heightened to that now, and so it's unusual for us to be able to go into a car wash to find people who are enslaved automatically, but it doesn't mean it's not happening here. And we've got 2 other areas that I've jotted down. The movement of drugs is often used by people who are in forced labour, and sex work. And what can we do? I think elected members have got a very large part to play and have been hugely helpful in our identification of vulnerable individuals. There's an LGA report that you're able to read, which gives you some helpful tips on how to identify people who are in modern slavery in your wards. And my offer is always make contact with me or one of your safeguarding leads, of course, to discuss it. But once we feel that we've identified somebody who might be vulnerable to slavery, we need to act quickly and hold extreme confidence. At that point, my responsibility is to pull together a disrupt panel. Disrupt is a statutory requirement for local authorities, which is serious and organised crime. And in this area of the Bath and North East Somerset and Avon and Somerset Police Force, we've decided to use our disrupt powers for modern slavery. That's not held throughout the whole of the UK, but we do that here. And it means we can bring together a multi-agency panel, for example, HMRC, Gang Masters and Labour Abuse Authority, Unseen Council Police, statutory agencies, and we have automatic data sharing ability when we use that umbrella.
Follow-up questions. So, do you have any numbers regarding, any figures regarding these sort of things? And how prevalent is it in Baines? This is a big problem for us. How big is the problem?
Our slide 10 has figures on it. I don't have the Baines figures. I could tell you anecdotally, but I think that our figures are quite small and I don't want to risk identifying folk. But in Avon and Somerset, we've got our 2024 figures. So we as the 5 local authorities, uncovered 42 cases of modern slavery with 96 potential victims. And you can see that it was split between labour abuse, sexual abuse, criminal activity, domestic servitude, and so on.
That's very interesting. Would it be possible for you to forward these figures to us? Because it would be quite useful to
They're
have
on
them
the
actually.
slides, on slide 10. Yeah.
And actually, just picking up on the LGA report part, perhaps if we could find that and then we can circulate that as well.
Yeah.
That might be a task for Mark. On my list now, I have Paul, Leslie, and then Joanna.
Thank you. I've got a number of questions, if that's okay, Chair. It's interesting that you've got these figures for 24, which is 42 cases and 96 cases. But in 21 and 22, there were 181 referrals to the Avon Somerset Police. And in 22-23, there were 304 referrals to Somerset Police, of which 189 were children. And this is a very good first start. But Chair, I would like to see this as an annual report. And as Liz said, I'd like to see far more detail gradually getting into it, so that we can actually make sure that the figures come down. Because quite frankly, the only acceptable figure to me is 0. If there's one person, then that's one person too much in our community. So, and I would like to, in future, add in a couple of other abuses, such as FGM and quotes, honour quotes, because there's no such thing as an honour killing. It's a dishonour killing. But what work are we doing with other organisations? I noticed the Salvation Trust is obviously, the Salvation Army is obviously clearly a key influencer, but are there any other organisations that we work with as a council to do this problem? Because it is, as you say, a very difficult problem to, one, identify, and then two, because of coercion and debt bondage and a number of other forms of control, it's very difficult to get people to admit to it, I imagine.
Yeah, I'd be pleased to bring detailed reports. I've brought a very high-level report because this scrutiny panel has never heard me speak about modern slavery previously. So I've taken the view that we needed to understand the definition and the context in our area before going into detail. And indeed, Chair, perhaps at some point we would look at the community safety remit and decide on what this panel would like to hear. We work alongside, of course, the Salvation Army, as you've already said, Councillor. They run the national organisation for the rehabilitation of people who've been enslaved, and work with people when they are waiting for a result on their slavery investigations. We, of course, work with our partners in the Community Safety and Safeguarding Partnership. So that's the 5 statutory agencies plus others who are involved in this, whether it's some of our local organisations who are in our care sector, our businesses through Bath Bid, looking at individuals who are at risk working within our nighttime economy particularly. So it's very far-reaching, and we do have the ability to call in partners and indeed certain parts of our council organisation to ensure that we get really good information and results. So I work very closely with public protection. We look at taxi licensing, for example, and our taxi drivers, to my knowledge, have raised 2 concerns with us comparatively recently about people that they've been moving in their taxis throughout Bath and North East Somerset that has borne fruit for us. So that's a small example, or one example, of the type of engagement that we do that bears fruit for us. In terms of FGM and honour killing, I will happily bring that to this panel. I think that my opinion would be it might sit well with domestic abuse. I understand the slavery link, but maybe domestic abuse, it would be something that we could combine there. We're having a domestic abuse conference on Wednesday of this week, actually, if anybody is coming.
I may well be coming to that. Paul, you look like you had some more questions.
Sorry. I'll repeat that. Very interesting that you said that taxis were being used. I hope that if we discovered that, any taxi driver that's involved in this immediately has their
I think,
licence
Paul, you may have
withdrawn.
got the wrong end of the stick on that one. I think Samantha might want to just explain. So I think you've got the wrong end of the stick on,
Did I?
that. Yes.
I frequently get the wrong end of the stick. Sorry about that.
I'll clarify that. Slave handlers are using local taxis to move their people around, and taxi drivers have reported their concerns to us.
Right. My final question is what support do we as a council give to victims that we have released or liberated or got out of their slavery control to ensure that they can kickstart their lives again properly on a decent basis?
Okay, so the Salvation Army is the body responsible for supporting and protecting victims once their case has been heard through the national referral mechanism. And they carry out an awful lot of work in preparing individuals for either staying in the UK if they're foreign nationals, to build a life, or indeed to repatriate to their home country. They provide temporary accommodation, they have support for preparing themselves to go into employment. They're given medical treatment and counselling and support to try to rebuild their resilience, and they're also given legal advice. As a local authority, we would be notified if that person was staying within our area, and we would class them as a vulnerable person, and then they would be referred through our safeguarding routes, our front door as usual.
Thank you.
I think to elaborate on that, the perpetrators, the people who carry out this offending, are often given what could be called a life sentence. So you're usually looking at something like an 18-year sentence. Their average 5 years. Their possessions can be confiscated. They can be forced to pay compensation orders to victims. And they can be given slavery protection orders, which means that their behaviour is monitored and they can't carry out this activity again.
Thank you, Samantha. Leslie, Joanna, and then Barrett. Actually, before Leslie asks her question, can I just double check, because we're, I think, agreeing that we'll have a report back here. You're not already reporting this to any other scrutiny panel, are you? Okay.
The BCSSP executive.
Okay, thank you. Which is stands for?
Beg your pardon, the Bath and North East Somerset Community Safety and Safeguarding Partnership. So Councillor Amanda Rigby sits on the executive now. She's my portfolio holder for community safety.
Thank you. Leslie.
Yes, thank you for the report. Of course, we don't think it happens here in Baines, do we? But I can tell you I've dealt with a case out in North East Somerset. I'm not going to be able to say any more, obviously, because it's really difficult to raise these issues anyway. But I think an area which looks very nice and very beautiful, people don't suspect it's happening, and it's more likely to happen here than possibly other areas. What I would like to ask is, do you do awareness raising sessions? I think it'd be really good, not just for this panel, but for other councillors to come along and find out a bit more, to see, you know, what the signs are to look out for, because I think it's probably happening under our noses most of the time. It's just difficult to identify it. And can I ask, are the modern slavery concerns integrated into the Council's broader safeguarding procedures and adult protection frameworks? And also training in a wider sense, is that available for frontline staff and providers to help them recognise and respond to the signs? Thank you.
Thank you. I'd be delighted to carry out member awareness. We can maybe create a small bundle of the work that we do in community safety and do some bite-sized pieces, even if they're online webinars that you could dial into when you're available. So yes, I'll take that up. Thank you. In terms of broader safeguarding, yes, absolutely. Adults, children and others have modern slavery and human trafficking as part of their standard training through our council training processes. And I regularly get invited to teams to talk about modern slavery and the identification where that team wouldn't traditionally recognise themselves as safeguarding teams. Yes, the final question about formal training for staff. We have a number of people throughout our organisation who are trained as first responders, which is the term that the government used for individuals who, once a person has been identified as being at risk, or indeed there's evidence that they are being enslaved, there's a particular procedure that we go through that has to inform the Home Office of our suspicion. That will happen either with or without the individual's consent, but we have a number of people who are in the position that we will assist others in the organisation or in other statutory bodies to do the referrals in. And we follow that referral then all the way through to completion.
Thank you. Joanna and then Barrett.
Thank you. Yeah, just picking up on the various points that people have made already in terms about getting councillors to know about this. I'm actually looking at Councillor Hardman in terms of your role as chair of council. Is there some way that we could have a report to full council and have some way that all councillors therefore know about this issue and therefore can get links to how they can know about when this is going on in front of them, or some sort of 5-minute presentation from an officer about the issue, because I don't think it's really well known about, or how we deal with it. And if the LGA are saying we are the vanguard of that and we don't know that, then there's something wrong.
Thank you, Councillor. Sorry. Thank you, Joanna. The main items that are brought before Council seem to be statutory reports, but I think there is an opportunity with Councillor's business that I could bring this up. So thank you for giving me the suggestion. Thanks.
I think I would follow up on that, Councillor Hardman, that we also, something I haven't mentioned, as an authority, we have a responsibility to be transparent in our slavery and supply lines. And that's a modern slavery statement that we have to renew each year through our procurement activities. So we could bundle that up in the information as well.
Chair, if I could just say, Sam, it would be really helpful if you could do a detailed report for me that I could actually then announce and read out to fellow councillors. Thank you.
Thank you. Finally, Barrett.
Thank you, Chair. I also echo the sentiments expressed by Councillor Crosley, Wright and Mansell. My question is, I don't know if this applies, but let me put it to you. I'm a restaurant owner. I go to India and I say I'm going to sponsor 5 waitresses or whatever, and please come over to the UK. I'm going to pay you £30,000, the minimum required, for 40-hour week, okay? And then they come over to the UK, they come to my restaurant here in Bath or wherever, and then when they've arrived here, I say, by the way, it's 70 hours, it's not 40 hours. I will give you your £30,000, but it is 70 hours. How do we disentangle this? Because I know these sort of things have been happening. You know, the person who has come in has invested a lot in that sponsorship because they know that at the end of 5 years, they have a right of permanent residence in the UK. So they look at it as, I will endure the pain, the exploitation, etc., so that at the end of the 5 years, I'm now free and I can be released from this place. I have permanent right of residency. Yeah? So does that come under modern slavery? And how do we even get to the bottom of it? Because the waitress, the cook or the chef, whatever, are not necessarily going to come clean and tell you, by the way, I'm being made to do this. Yeah? But I am aware that these sort of practices, I haven't dreamt it up, they are happening. I'd love to know what your thoughts are.
You're absolutely right, it does happen. And that would be a textbook example in a training session, for example. So yes, people are enticed into working for an individual or an organisation. I wish we could say that they're promised £30,000 and a 40-hour week. When that does happen, usually they don't receive that money, not all of it anyway. Often people are in bond, so they have to pay back. They are expected to pay back the sponsorship, so they might have to work extra hours, they might have to pay for their own protective equipment. If we were in another part of the country, in Lincoln particularly, where we have people who are collecting, cutting flowers for bouquets, you'll find that they might be told they've been given accommodation, but it would be in a caravan on site with no electricity, no sanitation, and so on. And they would be asked to buy their own elastic bands, which maybe sounds quite small for us. When you're on a very low wage, you've been promised money, you have to buy your elastic bands at sometimes 50p a time. Suddenly, you start to owe your employer money, even though you're working full-time and to full capacity. So we know that there are people that are hugely exploited. There are loads of barriers to people not accepting help or being worried about accepting help, and I've put those in slide 7 for you, the ones that we know that happen in our local authority. Often we find that people who have been enslaved will come to light maybe through a medical intervention, a GP or a hospital visit, where a professional has professional curiosity to find out why this person either doesn't have identification papers, or a GP might find that an individual never attends the surgery on their own. They've always got somebody with them who tends to speak for them, even if they have functional English. We know that there are people who have threats to their family, threats to their own life. And people are embarrassed, they're ashamed, they feel guilty that they're in this position, that they fell for it, and so they won't always speak up. What we do when we go into a premises where we suspect there are people in enslavement is we bring those individuals to a safe place. That could be somewhere as simple as the Guildhall, if we know that we have a room. We do this on an organised basis, so we'll know when we're going in, we'll know which professionals are leading the conversation, and we try to ensure that we have interpreters ready and available if those people are foreign nationals or not English speakers, and divide them so that we can have individual conversations with them, so that there isn't a collusion between individuals to protect each other or indeed to protect their handler if they have this kind of Stockholm syndrome. So we work really hard to try to assure and reassure individuals that they are a victim in this process and not a perpetrator. And that's the most important thing that we can do to try to gain trust. And we will then bring in the professionals from Unseen, the Anti-Slavery Partnership, to work alongside us.
But overall, what I'm hearing is this happens, it is happening, and there's very little we can do.
There's an awful lot we could do. I think if we had all of the money, time and resource and ability to identify individuals, we know that our our capacity is limited, but that shouldn't stop us from doing our best to identify victims and try to create a pathway to safety for them.
I think we'll look forward to the briefings and your sort of instruction, as it were, on what we can do. Thank you. I believe Paul would like to have the final word.
Yeah, when I read this report, the thing that struck out that I wasn't expecting was organ harvesting. When you say organ harvesting, where do those do they go to the NHS, and what does the NHS, what is the proviso that people who are receiving these organs go through to check that these are genuine donations from either someone who's had a traumatic accident, or they have given them because there's sort of for a family member? So what are the safeguards around organ use in the NHS? And if they don't go to the NHS, where is these organ harvesting going? Are they exported?
It generally happens abroad. I can't speak for the NHS safeguarding, but yes, people are transported abroad with a promise that they'll receive a significant amount of money, or that a bond that they already owe will be deleted.
Well, thank you, Samantha. I think that's been a real eye-opener for many of us. So, yes, I think we will very much encourage our colleagues to attend briefings too.
Thank you. I'm very enthusiastic about the work that I do. I'd be very, very happy to come back.
Brilliant. Okay, well, we're going to set a date for, at the very maximum, it'll be in a year's time, but maybe sooner might be better. So, thank you for your attendance of our panel. Right, we are now on the last two items. So the second to last item is the minutes of the last meeting on the 13th of October. Has anybody noted anything that is factually incorrect? Good. In that case, then, are we all happy to agree that they are the minutes of that meeting? Good, good. And then our last item is the panel work plan. Obviously, we've picked up several items from this meeting as well. Is there anything else that you would expect to see on that work plan? If you haven't thought of something for this meeting, then perhaps you'll let myself, Mark and Kerry know, and Liz know between now and our next meeting. Well, thank you everybody for attending, and I am now going to formally close the meeting. So thank you very much.